Good evening and welcome to this webinar of Fertilogix. This UNS is partnered with ISAR-MP, and we are having this webinar on a monthly basis. This is the sixth in the series, and the theme for this webinar is Invisible Becomes Visible. And it is pretty much in line with what we say at UNS, that what I cannot see, what the mitochondria can feel, CoQ10 is what makes the difference visible. So I'm Dr. Manish, Medical and Regulatory Affairs Head at UNS, and it's a great privilege and right to partner with Madam Dr. Archana Basair ma'am for this unique webinar. I request my marketing lead, Rishikesh, to give a welcome note. Rishikesh, over to you.
So thank you, Dr. Manish, sir, for setting the context and unveiling the topic. So dear esteemed doctors, good evening. This is Rishikesh and warm greeting from the Universal NutriScience. Definitely, it gives me an immense pleasure to welcome you all for this Fertilogix collaborative webinar series organized between MPSR and UNS. Definitely, we sincerely thank all of you for taking time out for your busy clinical schedules and join us today. Of course, the today's theme already been revealed that invisible become visible and radiology's role in infertility. It is extremely relevant current infertility practice topic. At UNS, we strongly believe in supporting CMEs through the ethical and collaborative initiatives. Today's webinar is actually a reflection of our commitment to meaningful academic engagement. So I extend my heartfelt thanks to MPSR, especially Dr. Archana Basair, and the coordinator, respected speakers, panelists, moderators, and all participating doctors for making this session possible. Once again, welcome to this session, and we hope that you enjoy today's insightful and enriching sessions further. So over to you, Bhakti, for further proceedings. Thank you very much.
Thanks, Rishikesh. What I'll do is in next a few seconds, I'll just introduce our office bearer and conveners and co-conveners, and also blessed to have all the star faculty out here. Dr. Kalyani, she is the technical director and senior consultant at Nova IVF Indore and Ratlam. We also have Dr. Rudri ma'am. She has been a university topper and is involved in reconstructive surgeries and cosmetic gynecology. We are also blessed to have Madam Dr. Brijwala ma'am. She is a consultant gynecologist and IVF specialist, managing director, Life Care Hospital. With this brief introduction of these esteemed faculty, I'll pass it on to Rudri ma'am for further proceeding. Ma'am, over to you.
Thank you, Manishi, and a heartfelt thanks to the whole UNS team for organizing the sixth webinar series of Fertilogix. And I extend a very warm welcome to all of you joined us today and all the respected faculty members. Heartiest welcome to you. Your presence once again reflects the shared commitments that we all have towards learning and collaborations. The theme of today's webinar is the role of radiology in the infertility, and the radiology is a powerful ally in infertility management from the diagnosis to decision making. And with the rapid evolution of modalities, radiology is just no longer supportive, but rather an integral component in optimizing fertility outcome. So today, with experts joining us across from India, without much ado, let me request our backend team to go ahead with the lamp lightning video, and then we shall proceed with our academic meeting. May I request our backend team to proceed with the lamp lightning video?
तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डवण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीम् वीणा पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थिताम् वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदा
Thank you so much, Bhakti. Now, can we have the CV of Dr. Archana Basir, ma'am, please? Thank you so much. So, let me take the privilege to introduce Dr. Archana Basir, ma'am. She is the senior ART consultant and director of Akash Hospital, Indore. Ma'am has held various prestigious past positions, and at present, she is serving as the vice president and chairperson MP ISA 2025-27, and ma'am is the joint secretary of ISPA 2025 to 27, and most importantly, ma'am is the Foxy presidential candidate for the election year 2026. Heartiest welcome to you, ma'am, and I request you to take over the session and kindly welcome our chief guest and our guest of honor for us. Thank you, ma'am.
Thank you, Rudri, for warm welcome and kind introduction. At the outset, let me welcome all the dignitaries on the dais for their presence and giving time out for this webinar, which we are doing regularly with UNS. And topic today is really, really good topic, which is very close to my heart, the ultrasound. And we have lined up a very good speaker, Dr. Sonal Panchal. We have a very nice panel as well with the panel moderator Ekika Singh and all the panelists. And the most wonderful thing today in the webinar, we have two stalwarts of Indian fertility world. What you can say, IFS, ISAR, and everything is our chief guest is Dr. Sonia Malik, and our guest of honor, Dr. Asha Bakshi. And I have really proud privilege to introduce both of them. So if I can have CV of Dr. Sonia Malik, and I know her CV by heart. Sonia ji is, like a kind of person you connect instantly because her presence gives so much of warmth, affection, and I think everybody loves her in our fraternity, especially the infertility world. And Sonia ji is a chief clinical mentor for Pan Nova IVF group, and I think she has held so many positions: chair advocacy committee IFS, she has been past chair infertility committee, and so many publications. Whenever you meet Sonia ji, she is like she has something new to talk about. And I'm really really happy that she has accepted our invitation, and in spite of her other commitment, she really is sparing time for us. So Dr. Sonia, for you the podium to give us advice and your inputs on the topic we have chosen. Over to you, Dr. Sonia.
Uh, Good evening, everyone. Thank you very much, Archana. My dear friends Asha, Brijbala, and of course Sonal from Dubai, and Amrita, Anu Agarwal. I can see so
Hello.
many of my
Sir.
friends, Ashmita, all of you. Uh, Coming to Indore is like coming to to your home. You have so much warmth, all of you. Such wonderful friends I have in Indore. Being the heart of India, you really are the heart and soul of everybody. Thank you so much for being so warm and caring for all of us. And thank you for those wonderful words that you spoke. I don't deserve them. But nevertheless, let me talk about this beautiful webinar series that you're doing. I have just been following all the titles and all the topics that you're covering, Archana. Each one is each one is better than the other. They are they are all so meaningful and so useful. I think no postgraduate should miss these webinars. So therefore, and the selection and choice of your topics as well as your speakers, everything speaks very well. So I really hope and wish that all these webinars are very well attended by people, and they make some use of it. I'm sure they would, because the topics are such. Coming to the topic of today, I think it is a very, very relevant topic. We all know that now ultrasound is our extended examination in infertility. I find that the juniors are not even doing an internal examination. They're just switching on to ultrasound as their first resort, which of course is not a good trend. But then ultrasound gives so much of information that you keep on trying to do and see what you can find over there every day. And also, what is most beautiful about the use of ultrasound in infertility is that every day you find that the changes that it is changing. You find different changes in the ultrasound depending upon the endocrinology and the physiology of the patient. That is something which has actually made us much more intelligent and wiser, I would say, in the field of infertility. And so we have come to depend upon this entity of ultrasound so much in our practice of infertility. I don't think we can ever practice infertility without ultrasound. And what better speakers than you and Sonal to tell us about ultrasound? So thank you very much. I'm sure everybody is going to benefit a lot from this webinar, and the panel, of course, is going to be very, very interesting. And I mean, it would be very different also, because the two girls that you have chosen, Ikaika and Mona Shroff, they both believe in bringing out subjects out of the box. Especially Mona, I know, is always thinking of something new. So therefore, I'm sure this whole thing is going to be very good. But unfortunately, I have to leave and I have to go and be in some other place now. So thank you very much, all of you. I'm sure we are all going to enjoy this. I'm staying here for some time till you begin. Thank you very much. Thank you.
Thank you, Dr. Sonia. Thank you so much for the kind words. And really, we all know that ultrasound is now our, like you can say, not two finger examination, the third finger examination. And it's a part and parcel of ONG practice. You cannot survive without ultrasound, knowing, doing it, or at least learning how the reporting is done and what you want exactly out of the ultrasound report, what you want from your scanning person. I think it's really amazing modality which has come. Once RCOG president was asked what is the biggest innovation of this century, and he said only three words: ultrasound, ultrasound, and ultrasound.
That's true.
This is what he said. I think that makes sense because it has really revolutionized our practice, the way we think, the way we do. I mean, sometimes we have reduced the surgeries, sometimes because it really helps us in counseling the patient and knowing exactly pre-operative what we are going to be doing and what we are going to be seeing. And it's very accessible and everybody can learn it, and it's economical as well as compared to MRI and CT scans. So thank you very much for really kind words and talking about this specialty and this modality. Now let me move over to our guest of honor today, Dr. Asha Bakshi. She's a dear friend, and Dr. Bakshi has been joining us from Dubai, and she is the one she is a very graceful, I should say, very intelligent person and a great friend. She is Secretary ISAR right now, member of Executive Committee AICC RCOG West Zone, and she is the founder chairperson of MP ISAR, and she has been Foxy Vice President. She has many firsts to her credit. She is the one who brought to our city the concept of practicing, till 5, and so many new things. When she came, she brought to our city, like CTG was not that popular. I think Asha Di has so many milestones to her CV. And the one biggest milestone I think we are all looking forward to it is that she gets into the second vice president position of ISAR, which she is going to be contesting this year. So all the best to you, Asha Di, and over to you for your inputs. And we can see all Christmas tree there behind you. So your inputs and your advice to us on the topic and this series.
Thank you. Thank you very much. Hope I'm audible. I am. Yeah. Thank you very
Yes,
much,
yes.
Archana, for the kind introduction. And I'm really thankful to Sonia Madam for being here today. And what I call her is she's the Malika of knowledge. She really knows the topic in depth. You can discuss her for hours together. And I've learned a lot, small things I've learned a lot in our day-to-day practice. And she is not only knowledgeable, but she has a big fan following. She's very affectionate and gives proper advice also. She's a good advisor also. So a very warm welcome, madam. And I would like to thank Dr. Archana Basir and her team, Dr. Brajbala Tiwari and Kalyani and Rudri. Dr. Archana Basir, we all know, is the shining star, and she's really very, very active and very hardworking. I have seen her, how he works, how meticulously she works, because we have been together doing so many conferences. And um, uh, and she's a taskmaster as well as has good leadership quality. Then uh, about Brijbala, am I audible?
Yes,
Hello.
ma'am.
Yes,
Yes,
yes.
Yes, ma'am.
yeah, yeah. And Brijbala, we all know, is again a silent person, but she is a very good worker and a very good clinician, and has a very good practice. Kalyani, again, very updated academician, doing very good work in infertility. Rudri is the upcoming star, and recently she has been awarded prize for her best paper in IFS, and very popular amongst the youngsters. And then today the topics selected have been
Hello.
reduces the
I think ma'am's
to
network connection.
hello, connection is
Yes,
not
ma'am,
there.
you are audible. Ma'am, now you are
Now
audible and
audible, ma'am.
visible.
Okay. So I think I'll be short because connection is a problem here. So I would like to welcome Dr. Alpana Chowdhury and Anu. Both are good friends. And
Your connection is somewhat.
So the connection is disturbing us.
Yes.
Hello?
deep webinar, because I think I'm not getting good connection here. So thank you very much. And I'm sure today's webinar is going to be very good. Thanks.
Thank you, Ashadi. In spite of being on vacation, I should say, or you have joined.
You sent me on this vacation. I was not.
I forced her to go, that you go, you must go. So I'm really happy that we, listen to each other so well.
Really.
The friends are for that only, isn't it?
Yeah.
Like, yes.
I can see Kanchan, who is from Indore.
Yes.
So
Yes.
hi, Kanchan.
Hi,
Yeah.
hi.
Yeah.
Thank
Very
you
nice
so
to
much.
see Indore
So
people.
please support me for the upcoming election of ISAR second vice president. So you please tell to your embryologists, your friends, and everyone, so that I can have help from all of you. Thank you.
Yeah, definitely.
Certainly. So we all for you, Ashadi. And I'm
Thank you.
sure the elections are going to be there from 11th January to 21st January. Yeah.
Yeah.
So just, yes, we all are looking forward to the elections and your win. So all the best.
Thank you.
Over to you, Rudri.
Thank
Further.
you, ma'am. Thank you, ma'am. And it's indeed a pleasure to have Bakshi ma'am, Sonia ma'am all together today with joining this evening. So thank you so much. And introduce our chairpersons and take the session further. Brijbala ma'am.
Yeah. So good evening, everyone.
Bhakti, can
and
we have
thanks.
the CVs of chairpersons?
Yes. So welcome you all for this MPSR webinar series. And may I have CV of Dr. Alpna first? So we are
Yes.
having first session
Yes, ma'am.
by Dr. Archana Base ma'am, and for that we are having chairperson Dr. Alpna and Dr. Anu Agarwal. So Dr. Alpna is very well-known figure, and she is from Bengal OBGY Society. She is managing committee member, and Dr. Alpna is professor and HOD at Medical College, Government Medical College. She is a peer reviewer of Jogi and International Journal of OBGY. So I welcome you, Dr. Alpna, to
Thank
chair
you, ma'am.
this session.
Your kind introduction. Yes, ma'am.
And next we are having Dr. Anu Agarwal. She is well-known figure in infertility, and she is holding the Vansh Fertility and Test Tube Baby Center, Aishwan Multi-Speciality Hospital, executive member of ISAR 2224, librarian UP-ISAR, joint secretary BOGS, and her field of interest is minimal invasive surgeries and ART. She had presented many papers in national conferences and published articles. So I welcome you, Dr. Anu Agarwal, for this MP chapter ISAR, and to chair the session by none other than our MP ISAR chairperson, Dr. Archana Basir. So over to you, both the chairpersons. Please go ahead with the scientific session.
Thank you, Dr. Brajbala Tiwari, for your kind introduction. So can we have a first speaker, the CV of our first speaker?
Actually, I think I'm being introduced, Dr. Alpana, by Rudri. So
Yes, ma'am. Thank you.
yeah, so we can start with scientific session if both the chairpersons permit, Anu and you.
Yes,
Sure,
ma'am.
ma'am. Thank you. Thank you,
Sure,
ma'am,
ma'am.
for inviting me here.
A very good evening to all of you. So what I am going to be talking today, I know that ultrasound has become part and parcel of our practice, especially in fertility practice, and we have a very good talk following my talk will be by Dr. Sonal for beyond the follicles. So I said, let me take a different thing like endometriosis and adenomyosis, imaging the enigma, especially in the infertility. Why we are taking this topic? Because what is happening, we all are monitoring the follicles. We are
बोलो
looking,
प्रश्न भेज दे तुमको चलो नंबर लो बेटा
we are looking at the endometrium, we are looking at the follicles, but what is missing is the myometrium. Myometrium is also very important part of the fertility, because unless the myometrium is supportive or there is
पर आओ ना जरा ऊपर
from endometrium. Somebody can respond that am I?
Yes.
No, ma'am, not very clear. At times we are missing the voice.
Archana ma'am, do you want to switch off your video? So then audio would be better.
I think ma'am's audio network connection is.
So, Archana Basir's ma'am connection is little bit not stable. So, may I request our chairpersons to just have an interaction for our audience so that we can till then ma'am can resume with the connections. Alpna ma'am and Anu ma'am.
Yes, ma'am.
Yes,
I
ma'am.
can understand about the situation.
Yes. Archana ma'am is just about to join in a while.
Actually, ma'am, I'm actually not an infertility specialist. But since
Okay.
Dr. Brajbala Tiwari
ये
has
चलता
requested
क्यों
me,
नहीं?
I'm a general. Actually, as a chairperson, I'm learning from you all.
Okay.
Nothing else.
Dr. Anu can put some words for this. Dr. Anu,
Yeah.
please.
Yes, Dr. Brijbala. Sorry, I couldn't hear you. What you said?
Actually, Dr. Basir's connection is lost, so meanwhile you can speak about the subject and little bit your inputs. Or shall we invite
Or if
Sonal
it
Madam first?
possible, yes, ma'am. If it is
Sonal
possible,
ma'am is
we can
here.
start.
She's the best
Yeah.
person to speak on.
Yes, exactly, ma'am.
Yes, I'm right here. Tell me.
Yes, ma'am. Ma'am, can we start with your lecture? Till
Yes.
then, ma'am
Yeah,
resumes the
of course,
connection.
of course.
Yes, ma'am. Yes. So, Bhakti, can we have the CV of respected Sonal ma'am, please?
Good evening and
May I
welcome,
request,
Dr. Sonal ma'am.
Good evening.
ma'am, I
Good
request
evening, madam.
our chairperson to kindly introduce Sonal ma'am for all of us. Alpna ma'am, could you please introduce Sonal ma'am for our delegates?
Yes, it's my pleasure to introduce Dr. Sonal Panchal. She is a consultant at Dr. Nagori's Institute for Infertility, and she is PhD in ultrasound in gynecology and infertility, and has also done masters in ultrasound on Obgyn and Donald in the university, and she also is presently professor of Duruvavik International University and National Academic Director of Iron Donor School India. She's the director of Center of Excellence of Iron Donald Inter University School of Medicine, Medical Ultrasound, Ahmedabad of India. She's National Advisory Board member for an International Journal of Infertility and Fetal Medicine. And she is the reviewer for Journal of Human Reproductive Sciences and published around 45 papers in national and international journals. And she has delivered more than 800 lectures and has great contribution in several books and has authored around more than 120 chapters. She has a keen interest in infertility, gynec ultrasound, and 3D, 4D ultrasound. Yes, Dr. Panchal, you can go ahead. You have a very good CV, which I can see.
Thank
Yes.
you. Thank you very much for those very kind words. Can somebody allow me to share my screen, please?
Bhakti?
Ma'am, you
Please
should have
wait,
the
ma'am.
screening sharing right. Just try to share it. You should be able to share.
Okay.
Ma'am, you can share it directly.
Attended and coming to our webinar.
Hello. Should I start?
Yes.
Yes, ma'am.
So yes, and am I audible? So the moment if my connection goes away, please let me know immediately.
Yes, ma'am.
Okay. So
Yes,
the topic is beyond the size of the follicle, imaging in infertility. What do we generally evaluate? Hello.
Yes,
Hello?
ma'am.
yes, ma'am.
You please continue, ma'am.
Yeah, there are lots of audios on.
Yeah.
So if you can please
Yes,
switch off those.
we'll do it. Thank you.
What do we generally evaluate for the to decide that the follicle is mature or the endometrium is receptive? The commonest answer would be follicle 18 millimeters, endometrium 8 millimeters, trilaminar, and you can give the trigger. This is definitely insufficient, I would say. What is missing? Female reproductive system, which is a very dynamic endocrinological system. It has, several hormonal changes going on continuously, and these changes, they reflect instantaneously as vascular changes, and therefore, and after that morphological changes, therefore, it is very important that whenever we are evaluating the follicle or the endometrium just for its anatomical status in the form of follicular size or the endometrial thickness, it is very, very important that we do a Doppler and we find out what are the vascular changes happening and interpret them into hormonal changes. This would give us probably the most precise idea about the functional status of the follicle and the endometrium. We can do Dopplers, and so that means Doppler plays a very important role. Not only that, it is also 3D ultrasound, which is very important because the structures that we are seeing, the follicle, the endometrium, and even for that matter, the uterine, the Mullerian abnormalities, or I would say uterine pathologies. This is where we also need 3D for a lot many applications, and it is of a great use to decide our decisions. So if we divide this discussion into parts, we can say we'll see the role of this advanced ultrasound to decide the stimulation protocols, and then to design a stimulation protocol such that it would result into no OHSS, no cancellation of cycles, and so on. That means a safe and individualized protocol. We would do we would discuss it to decide the time and the type of trigger, and also maybe if it's an IUI cycle, the time of IUI, and of course for the assessment of the luteal phase. When it comes to deciding the stimulation protocol, most of us and most of the literature that we have been reading talks about AMH, FSH, AFC, age, and at the most BMI. These all factors are chiefly responsible for the number of follicles that will grow. That means they talk about the reserve. But when it comes to actually deciding the dose of stimulation, it is not just the total dose of stimulation which is important. It is also important to decide what would be the daily dose of gonadotrophin. And this is because unless we cross the FSH threshold, the follicular growth is not going to occur. And this threshold, to reach this threshold, you have to have a certain amount of FSH in the stromal flow so that that FSH will disperse into the stroma and reach the antral follicles to develop FSH sensitivity. That means that there are two questions: how many follicles I will be able to grow, and more importantly, to develop those expected number of follicles, what amount of or what daily dose of gonadotrophin or FSH I will require. So starting with the first one, and that is counting antral follicles, of course, a pure 2D assessment. You can just scroll across the entire ovary just in one direction, eyeball and count the follicles. As long as the number of follicles are 12 to 15, not more than that, you are as accurate as 3D. But we need to remember that when we have multiple follicles, when we have PCOS patients, that's when the human error is going to be very high if we are going to use the manual way of calculating the antral follicles, and that is where 3D comes into role, the special software wherein all the follicles can be color-coded. Not only color-coded, they're counted, not only counted, you can also assess the XYZ diameter, mean diameter, and volume of each and every follicle. And this is a very detailed examination which takes the machine only a few seconds, and a huge amount of information comes out. It is important here also to understand that if it tells us XYZ diameter, mean diameter, and the volume, probably it is either the mean diameter or the volume derived diameter, which needs to be followed every time. What is volume derived diameter? When one makes the sphere of the same volume as the volume of a structure and takes a diameter of that, it is a volume derived diameter. This especially has more meaning when we come to the pre-trigger scan, and we will discuss that a little later. Knowing the size of antral follicles is important because it needs to be understood that follicles up to 6 millimeters, they are not FSH sensitive. And therefore, if you start stimulation when there are no follicles which have grown to beyond 7 or 8 millimeters, that's when there is a very high chance that the patient would present as a resistant PCO patient or a patient resistant to gonadotrophin. And when you feel so, you definitely would increase the dose. As soon as you increase the dose, and especially if you make it double, there would be blow up of the follicles. And therefore, it is very important to understand that unless the follicle has reached the FSH sensitive stage, please don't increase the dose of gonadotrophins. This is for the safe stimulation protocols. Now, so that is why you need to know the size of the follicles, whether it's an IUI or it's an IVF stimulation, especially when it is about the PCOS patients, or if I say that we are talking about the follicles less than 6 millimeter, more than 6 millimeters, if you don't want to go into a more detailed assessment in the sense, know the size, individual size of every follicle, you can also group the follicles using Sono AVC and Trill software into FSH sensitive follicles, which appear here as white, and FSH non-sensitive follicles, which appear as yellow. And this also would be a very significant, not only a time saver, but a decision-making tool to decide stimulation protocols in cases of PCOS patients. Coming to the ovarian volume, which is the second important parameter which can decide the ovarian reserve, of course, can be done on 2D ultrasound, but need to remember that whenever the ovary is not round or oval, it is not spherical or ellipsoid, and it is longish and irregular in shape, that's when the 3D volume, which is calculated by vocal software, is a very useful addition. Coming to the assessment of the ovarian response, that means the daily dose of gonadotropin that we require. I've already told you that the antral follicles, they do not have any blood supply of their own. They depend on the dispersion of the FSH into the stromal tissue. This dispersion starts only when the blood, ovarian stromal blood FSH levels reach a certain extent. And to allow that FSH threshold to be reached, you need to adjust the doses of the gonadotropins in the to be injected, because it is to be understood that if the blood flow to the ovary is more percentage of total gonadotropin loaded into the patient system is going to flow into the ovary every cardiac cycle, and the FSH threshold will be reached easily. But if the total blood flow to the ovary is less, that is when less percentage of total gonadotropin loaded into the patient system will flow into the ovary every cardiac cycle. So to allow the FSH to be FSH threshold to be reached, you need to put much more into the patient system. So naturally, if the blood flows are good in the ovarian stroma, the patient is a good responder. If the blood flows to the ovary are less, patient is a poor responder. And this is what has been mentioned in all these different literature evidences. Measurement of the ovarian stromal flow in the early follicular phase is related to the subsequent ovarian response in the IVF treatment. And this also holds true when you are using even the 3D power Doppler parameters like vascularity index, flow index, and vascularity flow index. It needs to be remembered that the patients who are old aged, even if the ovaries otherwise look the same, say for example, an ovary of 4 or 5 cc along with about 10 follicles, 10 antral follicles in a patient of 25 years and in a patient of 35 years, it is always going to be a major difference in the blood flow between the two, and that is what decides what would be the daily dose of gonadotropin. It is not only I would say age sensitive. It is also the blood flow is also sensitive to different pathologies, especially endometriosis. And even in patients with endometriosis, it is the blood flow to the ovarian stroma which will decide whether the patient is going to be a normal responder or a hypo responder. This is not only true for the 3D power Doppler. Even if you are using the 2D Doppler, the PSV also correlates with the ovarian responsiveness, and those who are poor responders will have a lower PSV. And from various literature evidences, it has been found that lower RI and the higher PSV tells you patient is a hyper responder, and higher RI and the lower PSV tells you the patient is a poor responder. So that means there's a very important role for both the Doppler as well as 3D when it comes to the decision making on the stimulation doses when gonadotropins are used for stimulation. If we say it so, it is very important as to how you would decide the stromal flow. You need to locate the hilar vessels first. Let's go back. And we will locate the hilar vessels first. These are the vessels which are seen in the long axis extending beyond the ovarian surface, and they're pulsatile. From these hilar vessels, if we scroll across, we will lose the vision of the hilar vessels. And that is when we are seeing still some vessels, still some color in the stroma. These are the stromal vessels. Pick up the brightest ones. And when you measure the flow of those brightest looking vessels, that is when you get a spectrum. And it is this spectrum from which we can calculate what would be the RI and the PSV for those patients. What more will the stromal flow tell us? Yes, it tells us how is the response. One. But the second important thing is that whenever the ovarian stromal blood flow is less, it means that the LH may be required. Why? Because it is LH which is responsible for the stromal vascularization. It leads to new angiogenesis, so more blood vessel formation, and that is why the PCOS patients have an abundant blood flow in the ovarian stroma, because they have high LH. And it is same LH which is also responsible for the low resistance flow by the mean of catecholaminergic stimulation and leukocyte cytokine activation. That means the patients with PCO who have high LH, they also have a low resistance flow. Because they have low resistance flow, they have lots of blood vessels. Therefore, naturally, they are hyper responders. But this is the PCOS group. If it is a non-PCOS group, if it looks like a normal reserve patient or it is a poor reserve patient, and in this patient, if you see that the ovarian stromal blood flow is less in abundance, or there is high resistance flow in the ovarian stroma, it tells us that the patient is going to respond poorly, she is going to require higher dose. But on the other hand, it also tells us that either LH is low or the LH bioactivity is less, or there is a receptor polymorphism, LH is not perceived, and it is in these patients that the LH supplementation is required. You follow the Poseidon criteria, it tells you only after you get a failure. Here, because you are good doing Dopplers, you know even before you have started stimulation that these are the patients who are going to require a FSH, LH supplementation. Stromal flow therefore tells you about dose of gonadotrophin, dose of FSH, and whether you require LH supplementation or not. Coming to the follicular dominance, this can be also confirmed only by the Doppler. Remember that dominance is not just the size; it is the sensitivity of the follicle to FSH, and this sensitivity can be confirmed by the blood flow. As I told you, when the FSH starts dispersing from the stroma and it reaches the antral follicles, that's when the antral follicles recognize this biochemical and develop receptors to that, and that is why it develops the blood flow. So the blood flow to the small follicles, 8, 9, 10 millimeters, tells you, and perifollicular blood flow in these vessels tells you that yes, this is a dominant follicle. Coming to then the pre-trigger scans, and that is where we need to decide the size of the follicles to give a trigger. 18 to 24 millimeters is what we understand. This usually correlates with the volume of 3 to 7 cc. 12 millimeters is usually about 1 cc, and 0.6 millimeters is about 10 cc. I did already tell you that when you want to take this decision correctly, and especially in IVF cycles, when there are multiple follicular development, because the follicles are compressed by each other, none of the follicles is round or oval, and therefore you cannot depend on the mean diameter. You have to take the follicular volume in this cases, and you may convert this follicular volume into the follicular diameter. This is what is the volume derived diameter. I'm repeating this, I know, but what you do is you take the volume of that irregular shaped cystic structure and you make a sphere of that same volume, and the diameter of that is your volume radius diameter, and this is the correct size decision. This is the correct column to take a decision on the size of the follicle and decide the time of trigger. Apart from this, you may see a hypoechoic halo surrounding the follicle, which is about 24 to 36 hours before, but you may also see a tiny cumulus-like structure, a tiny solid projection. You need to confirm on 3D ultrasound that this is definitely a cumulus, or you can do it on the 2D ultrasound by scrolling across. This is an important marker for a presence of a fertilizable oocyte in the follicle, and this is especially important in the patients who are poor responders or those who present as unexplained infertility or unexplained failure of conception, even when you have taken the decisions on the trigger by Doppler. So that is the role of 3D in the pre-trigger scan, and then we go to the Dopplers for the pre-trigger scan. Yes, it is true that when you want to give a trigger, you should see that the RI of the follicle is less than 0.5 and the PSV should be more than 10, and vascularity should cover at least 2/3, preferably 3/4 of the follicular circumference. But before this, we know that before the surge actually starts, LH surge, there's going to be an estrogen surge, and it is this estrogen surge which is a marker to tell you the follicle is good in quality, because as you all do, because when you're doing your why do you get estradiol level done before you give a trigger for your IVF cycles or for your IUI cycles? Also, you would see that the estradiol levels is 150 to 200 picogram per ml per follicle, and that means that estrogen secretion is sufficient, so the follicles should be good in majority. Similarly, when the final estrogen surge starts, that is when the perifollicular RI falls to less than 0.5. So when the follicular RI falls to less than 0.5, it tells you, yes, the estrogen production is adequate. That means it is RI which tells you, it is Doppler and RI of the perifollicular flows which tell you, yes, it is a good it is a good quality follicle. The follicle has reached a functional maturity, and after that the rise in PSV tells you that the LH surge is going to start. It is this follicular Doppler which decides the oocyte recovery rates, better flow, better oocyte recovery rates. Not only that, very important is that if the oocytes are hypoxic, that means if the flow surrounding the follicle is inadequate, there is a high frequency of abnormalities of the organization of the chromosomes on the metaphase spindle, which may lead to segregation disorders and catastrophic mosaics. If the PSV of the follicle is less than 10 centimeters per second, there is a high chance of developing an embryo with chromosomal abnormality. If I say so, does it strike us all that here, today's era, when we are all working very hard on fetal medicines field, and we want to diagnose trisomy 21s early, and we want to get rid of them before they turn viable, would it not be very helpful to eliminate or to decrease significantly the incidence of trisomy 21s, at least in treatment cycles, if not in natural cycles? We are not going to do this. We are not going to follow the follicle before the trigger. But if you can do this for your treatment cycles, you can definitely decrease the incidence of trisomy 21s significantly in the treatment cycles. Coming to coming to then the type of trigger, again, there also your 3D and the Doppler plays a very important role. Doppler, of course, would tell you about the follicular maturity, but more than that, you need to decide what to give as a trigger. Do you want to give HCG? Can you take a risk of giving an HCG because that is a risk of OHSS, or you want to give you want to give an agonist? Now, that, of course, there are literature evidences which say that the number of follicles, if they're more than 11 millimeters, more than 25, that's when you do not want to give a trigger. And these number of follicles can only be counted confidently and measured also by sono AVC. So that sono AVC plays a very important role. And whenever, and this is very interesting because it says follicle larger than 11 millimeters. It's interesting to understand that follicles which are medium sized, 11 to 14 millimeters, are the follicles which share FSH and LH receptors. And therefore, whenever there are more number of medium sized follicles, that's when there is a higher risk of OHSS, because these follicles, because they share FSH LH receptors, with the surge, they keep on growing. After the surge, they cannot luteinize. These are the source of VEGF. To prevent multiple pregnancies for IUI, again, you avoid giving HCG when there are multiple follicles larger than 16 millimeters. So that means your Doppler and your sono AVC and your 3D ultrasound plays an important role to decide when to give a trigger, what to give as a trigger. Coming to the endometrial assessment, which is a very important part nowadays, because majority of our ART cycles are now converting into frozen transfer cycles. Remember, bring the endometrium right in the center, zoom the image, and take the measurement from the outer margin of hyperechoic line to the outer margin of hyperechoic line, perpendicular to the central line. But it is important that whenever the endometrium is persistently thin, but the vascularity is good, or the endometrium appears thicker, but you fail to get implantation, that's when endometrial volume assessment is very important. And if the volume of the endometrium crosses 2 cc, that is when the chances of conception are very good if the vascularity is good, whatever the thickness. But if whatever the thickness, the volume is less than 2 cc, that's when the chances of implantation are significantly low. You can use 3D with vocal software, and we will just play this clip a little faster. So you can use vocal software to calculate the volume of the endometrium. Remember, when you're using vocal for the endometrium, we should take a step of rotation of only 9 degrees. You may spend some more time, but you get exact volume of the endometrium, and that would decide the receptivity of the endometrium. And there are several references, literature evidences to the same. We need to remember that even if the follicle is good and the estrogen is being produced, it is important to complete the loop. We need to decide whether this estrogen is adequately acting on the endometrium. So you need to assess the growth rate of the endometrium, which should be 0.3 to 0.5 millimeters a day during the entire proliferative phase. You need to confirm that it develops a good morphology, a multilid endometrium, and it also shows vascularity in the endometrium. Moreover, the cervical mucus and the hyperechoic of the cervical glands also tell you that the estrogen is reaching the cervix, and the cause of infertility is not a cervical factor. Endometrial vascularity, if I said it reflects the presence and action of estrogen on the endometrium, you must confirm that the vascularity reaches the inner central line of the endometrium, and it covers a vascular area of at least 5 millimeters square, which is important for the implantation to occur. If this vascularity, that means the Doppler of the endometrium is very important. If you don't see this, it is a strong marker of failure of implantation. If you see it, it is not just a marker of implantation, it's also a marker for ongoing pregnancy. And if you don't see the vascularity in the inner layers of the endometrium and still you see that the implantation has occurred, remember the chances of abortion are very, very high. That means vascular assessment of the endometrium is as important as the vascular assessment of the follicle. And it should have a low RI, where the RI is less than 0.59. And it should have at least 5 millimeters square area, or at least 5 vessels closely placed from both the sides, reaching the inner layers of the endometrium, and volume assessment may be done whenever required. Uterine artery Doppler also, again, it is well known that it is important. PI should be less than 3.2. If it's an IVF cycle, the mean uterine artery PI, if it's an IUI cycle, on the dominant side. It is Doppler which also helps you beyond the start of the surge, with the rise in LH, the PSV of the follicle increases. So if you're seeing that the RI of the follicle is low and the PSV is more than more than 15, which means that the surge has probably already started, and it has been proved beyond doubts that whenever the PSV of the follicle is high, that is when earlier IUI gives you better results. You may go for double IUI if moderately high PSV, but if it's very high, more than 25 centimeters per second, you can do just an early IUI at 12 to 14 hours. So that means not only deciding the time of trigger, it's Doppler, which also helps you decide the time of IUI, and it also helps you decide whether the progesterone effect is adequate or it is higher. It's optimal or it is higher. We know that progesterone exposure is required before the luteal phase so that the progesterone receptors would develop, and that physiological effect of progesterone, which is seen only for 24 hours after progesterone exposure, and which is within normal limits of normal levels of progesterone, fluffiness of the outer margin of endometrium, tells you that the progesterone effect has started, but it is within physiological limits. duration wise, and the amplitude wise. And therefore, with this, you can go ahead with your interventions, IUI, or starting progesterone, or giving to prepare the endometrium for embryo transfers. But if you start seeing hyperechogenicity in the outer margin, that means it is hyperprogesterone, and this is an ill effect that is not, non-physiological effect of progesterone. Decrease in the vascularity along with that fluffiness, and also rise in the uterine artery PI tells us about the same physiological process. So decrease in the thickness, fluffiness of the outer margin with no hyperechogenicity, decrease in endometrial vascularity, increase in uterine artery resistance. With mature follicle, go ahead with IUI. With immature follicle, indicates premature LH surge. And if it is seen with the rupture of the follicle, tells you it's an immediate rupture and you can use that cycle. Luteal phase evaluation also requires Doppler. It is corpus luteal RI, which tells us progesterone production is adequate. It is the vascularity of the spiral vessels seen in the mid-luteal phase with an RI of less than 0.52 tells you, yes, there is enough progesterone receptor development and everything works well, along with the low uterine artery PI. Because you can understand the normal luteal phase better, you can also diagnose both LUF and LPD on Doppler. B mode ultrasound only tells us about the anatomical status of the follicle and the endometrium, but the advances, the Doppler and the 3D tells us not only about the functional status and the hormonal changes, it adds to the global assessment. Thank you very much for the patient hearing.
Excellent, excellent, Sonal. What can I say?
Thank you, Archana.
I mean, always it is so wonderful to listen to you. Every time you get something new, and it just clears everything. It's like a amazing. You enter into
Thank you so
different
much.
world altogether when you talk.
Thank you very
I'm
much.
sure what chairpersons have to say.
Yes,
Because
exactly.
I think this lecture is like, every time like, okay, I'm going to do how Sonal Panchal does it.
Thank you very much, Archana. Thank you very much for those really, really loving words, but I doubt it's right.
I know my daughter still will take the picture out and just, okay, let me see Sonal ma'am's book and see how she would have done it.
Thank you so much. Thank you so much.
Thank you, Sonal ma'am. It's a treat to our eyes, to ears, to listen to you, ma'am. It was a wonderful lecture.
Thank you. Thank you.
Thank you, ma'am.
Thank you.
Can I ask a question, Sonal?
Of course, please.
You know what has been recently, like I'm facing like couple of patients, as you said, that do IUI and the risk of OHSS. So what you do, like there are multiple follicles, just you're given the oral ovulations and maybe you're given gonadotrophins and OHSS. So you do counseling and say, okay, we are not doing your IUI cycle, or is there anything you can add? I know you are a radiologist, but we are more of a infertility specialist now at Nagori Center. You are guiding the gonadotrophin doses as well.
No, the first thing is that if you follow the baseline score, you usually don't develop multiple follicles. But by chance, if you have developed multiple follicles, and if it is a gonadotrophin cycle, what we would do is, as soon as we start seeing multiple follicles of 10, 11, 12 millimeters, we would decrease the dose by 1 step. So that would prevent the growth of the smaller follicles. They will just get arrested at that stage, and only 1 or 2 or maybe 3 follicles may grow further. But if you have seen it a little later, we still prefer to give them a dual trigger or an agonist trigger, depending on what is the number of medium-sized follicles. If the medium-sized follicles are truly too many, more than 6, we will not give any HCG, only agonist trigger. If they are between 3 and 6, we would give a dual trigger. And if they are less than 3, we can give a full dose HCG. So yeah, we are usually afraid, but if the follicles have not even reached 10 millimeters, that's when usually we don't have a problem. But as I told you, you can plan your triggers, which will help you.
Yeah, I think it is, very tricky balance, isn't it?
So
Like,
that's why the Sono AVC is very useful, because we can exactly find out what are the size of the follicles, and then we can decide. But God's grace, and I can swear that last 23 years, I've not seen a case of OHSS in our clinic.
That's great. I mean, that makes us worry. Sometimes people just give oral ovulogens, patients just come and you see, oh my God, so many follicles are there. What to do?
It
So,
does happen sometimes, yes.
and sometimes what you do, if a patient is constantly coming to you continuously, like for 3 cycles, she's coming, she has 3 follicles in her one ovary, and in one ovary is all the time showing you the, luteinized, unruptured follicle kind of a situation. AMH is good.
So what to do?
How
Your
do you
question
really
is
proceed with
what to do if it turns out to be an LUF, right?
Yeah.
See, if you say they have taken oral ovulogens and they have multiple follicles, usually they have taken a CC. And CC does lead to high LH, and persistently high LH with lots of follicles may result into LUF truly. But many a times it does happen that we are not seeing an LUF, we are actually seeing a corpus luteum. But because the fibrin would be very, very thin, unless you increase the gains, you may not see those tiny, scanty fibrin strands, and you start believing it is probably an LUF. Doppler may help you there, but otherwise, CC cycles, there is a possibility these follicles, if at the time of trigger they have not shown flows, they may go into LUF. It's very likely. Those cycles, you have to take them on letrozole and prevent rise in LH anymore.
Okay.
Ma'am, how to differentiate between this LUF and corpus luteum cyst? Through
If the corpus luteum is a ruptured follicle, there always has to be a hemorrhage inside, is the first thing, and the walls are isoechoic. But if it is a luteinized unruptured follicle, it is unruptured. There can never ever be a hemorrhage inside. You will see low level echoes, you will see hyperechoic walls, but you will never see any fibrin, any fishnet pattern, any honeycomb pattern. You'll never ever see in that. So if you are seeing blood, it is a corpus luteum. If it has inadequate flow, it is an inadequate corpus luteum. But if you are seeing hyperechoic walls and only low level echoes, no hemorrhagic echogenicity, that is your LUF.
Wonderful. Thank you, ma'am.
Thank you.
Any other questions or?
Ma'am, just one more question can I ask? Ma'am, sometimes we find small fluid in the endometrium during periovulatory phase.
So periovulatory phase, seeing fluid in the endometrium is very common, and it is very much normal. If it is just a sleet-like, which is not measurable and which is transient, it comes and goes away. It doesn't last for more than 24 hours. This is just a sign of a good estrogen level. Nothing to be done for that. You can go ahead with your transfers, or you can go ahead with your IUIs. But if it is measurable, if it is persistent for more than 24 hours, and that is when you need to investigate it. First, rule out isthmosil, which may be a cause. Second, you can treat them with a course of antibiotics, which rules out endometritis. If that doesn't help, you can aspirate it and get a culture done for it. And if that also comes negative and still the fluid persists, that means your culture is negative, or it's already been treated and still the fluid persists, we in some cases do aspirate the fluid and do a transfers. So just before the transfer, aspirate the fluid and do it. Since it was a sterile fluid, it may not cause negative impact.
Can we get positive pregnancy if we aspirate the fluid and transfer? I have done.
Yes. Otherwise, I would not tell you, right?
That's great, ma'am. I have done it in 2 cases, but
no, but you have to confirm that there is no infection anymore. You have to confirm that the fluid is now sterile, because you have treated with antibiotics, which you have done. You have decided by culture sensitivity. You have treated it. Nothing is, and plus the vascularity has to be there. In spite of fluid, if there is vascularity in the endometrium, it works.
Thank you, ma'am.
Ma'am, I have a basic gynecology practicing a bit of infertility. I have a one question for you, a very basic question. That is, if you have a delayed, if you have a LUF in the pregnancy, in this cycle, how should I prevent LUF in another cycle?
No, LUF doesn't happen in every cycle. LUF only occurs when your trigger is given before the follicle is functionally mature, or the trigger agent is inadequate in quality or quantity. If the follicle shows, you have confirmed the Doppler, and if it shows good flows, that means the follicle is developed at LH receptors. And after that you give LH, it is going to respond. It cannot go into LUF. But if, I mean, in that case, if you have seen flows and still it is not functioning, that means you need to check your trigger agent, whether it is it has, the cold chain has been maintained, the amount was adequate, the patient has not missed it. Otherwise, LUF doesn't appear. Remember that if you have multiple follicular growth, one follicle which is mature may rupture and the rest can go into LUF, and that is not a problem. One normal composite, any number of LUFs are okay.
Actually, what happens is when you think of giving IUI, when we see more than four follicles getting matured, we discard that cycle. So, yeah.
Then it will go into LUF, na? Then it will go into LUF, which will resolve on its own also.
Okay. Thank you, ma'am. You are an encyclopedia. So much to learn from you, ma'am.
Thank you.
So moving on, we'll be going to the next session.
Thank you, Sonal Madam, for an enlightening talk. And shall we move to next session by none other than Dr. Archana Basir Madam?
Thank you, Brajbala. But I
Ma'am,
think there is somebody on two things. Someone is using either mobile and laptop or some other webinar attending in between. There's a lot of disturbance happening.
Yes,
So
ma'am.
can UNS people check it? That where is happening, what is happening?
May I request Dr. Alpna ma'am to invite Basir ma'am for her talk now?
Good evening, ma'am. Once again, it's my privilege and honor to invite Dr. Archana Basir. I think her talk will be as good as the previous speaker. Hoping to hear you.
Thank you very much. After listening to Sonal, I slightly in between modified my talk because it was so beautiful talk, and there was something, she has covered so beautifully the endometrium and all. So I am now switched over to stage-wise assessment of endometriosis on ultrasound, because that is very, very important when you are practicing gynec and especially infertility, because endometriosis is a very common problem and it is a costly chronic disease, and nearly 10% of women of reproductive age group suffers from endometriosis. And let me tell you a little bit of facts and figures of endometriosis. It is 1 in 10 women have endometriosis, and it takes an average of 7 years for most women to get diagnosed. I am sure many of you would agree with me. A young girl or a woman coming to you who not been able to conceive, being reported as a simple cyst or cyst in her ovary, and as Sonal has said, you have to put, like the fine echos, you see that inside there is a ground glass appearance or echo structure. You have to really see it with the gains. You have to do the gains adjustment and all, and you will be able to see that, oh my God, it wasn't a simple cyst, it was endometriosis. Sometimes endometriosis can get confused with or misdiagnosed as irritable bowel syndrome. And remember, it is the second most common gynecological condition after the fibroids, which can present to us in our clinics, and especially with infertility. So just overview of my talk, I'll be talking about the definition of endometriosis and adenomyosis, ultrasound appearance of endometriosis within the pelvis, how to assess for pelvic mobility, and what to look for during an endometriosis scan. So if you look at the endometriosis, it is presence of endometrial-like tissue outside the uterus, which includes a chronic inflammatory reaction, endometrioma, adhesions, and endometriotic nodules. It can be deep or superficial. Now we have diagnostic modalities: ultrasound, MRI, endoscopy, biochemical screening, and histopathological definitive diagnosis. But the most preferred modality for assessment of the pelvic pathology is ultrasound, and out of which the transvaginal ultrasound is the route of the choice. And why ultrasound? Because as we have already been discussed and talked, that it is widely available, it is cost effective. Ultrasound can pick up ovarian lesions, endometrioma, and it can pick up deep invasive endometriosis. A scanning technique, I'm not going to go into detail of it. Grayscale imaging can be improved by using HI, CRI. With this, even subtle textural changes. What is important is to see the texture, and it is associated with endometriosis, can be appreciated. Surgical staging of endometriosis, all of you, those who are doing laparoscopic surgery, or maybe some PGs who have joined, that how to stage the endometriosis. Stage 1 minimal, stage 2 mild, moderate disease, and a severe disease. This is a pictorial representation of minimal,
we are not
mild.
seeing your slides on
Ma'am,
the screen.
slides are not visible.
Slides, ma'am.
PPT.
ऐसे कैसे हो रहा है भाई? Okay.
We are watching you, not the slides.
Oh, मुझे watch करने का. Let me just go. I might.
Please reshare your slides. Rest all participants are requested to be on mute, please.
How is it? Is it still the same?
Ma'am, PPT not visible.
That's really strange.
आप उसको मिनिमाइज मत कर दीजिए, क्लोज कर दीजिए पूरा पीपीटी को। आप पहले क्लोज करके फिर रीओपन करिए।
I'm going in slide slow, like how I standardly do.
आपने मिनिमाइज किए होंगे ना, वो मिनिमाइज को आप क्रॉस कर दीजिए। आप फिर डेस्कटॉप से फिर रीओपन करिए, मिनिमाइज को ऑफ कर दीजिए।
Okay. Then should I close it again and
Yeah, you close it. Yes, you close the previous one and again go from the desktop to the new one.
I'll just wait, otherwise we can start with the panel. Today is like happening.
मैम रीशेयर में आप एंटायर स्क्रीन शेयर कीजिए या एप्लीकेशन इन विंडोज में पावर पॉइंट प्रेजेंटेशन कीजिए।
I will just check it.
You can continue without slides. It's okay.
No. That's very important. So I will. I'll just come onto the Zoom again and. Okay. So I'll share my thing.
Just leave the group and again join. Now it's
Madam, it's visible now.
Yes, visible. Please go on the slideshow mode.
Technology sometime you.
It
Okay.
happens, ma'am.
Thank
Yes.
you so much for being patient. And I think I've already discussed and talked about this. So I'm just going to come on to this thing, like this is a pictorial thing, minimal, mild, moderate, and severe disease.
Ma'am,
And
slides are not moving.
what is the problem?
Yes.
So should I stop the share again?
No. You go on the slideshow mode, madam. Just
You're not seeing the
adjacent to
slides?
animations. Yes.
Are you seeing the slide or not?
Yes, ma'am. We can see your
you
slides.
just
Ma'am, first slide
entered
is
all the
visible.
time. You entered, you will get it.
Can you see structures involved in endometriosis right now?
No,
No,
we are
no.
seeing the first slide of yours. Top left में ma'am, from the home button you can, there are animation transition, उसके बाजू में slide show है, उस पर एक बार click कीजिए. Please click on that slideshow mode.
I'll stop share first. Okay.
Okay, no issues, ma'am.
And then what are you saying? What do I do?
एक बार फिर से रीशेयर कीजिए.
Some problem is happening. It's not getting. Is this slide visible?
No, ma'am.
Ma'am, previously it was visible now.
I don't know. I think we should go on to the panel because this is something which I've not been able to figure out because it's so regularly doing. But what are you saying, Rishikesh?
मैम आप
Slideshow?
रीशेयर करके स्क्रीन जैसे शेयर करेंगे or else you can WhatsApp me the PPT, ma'am. I'll just
ठीक
show
है ना,
you.
फिर सबका टाइम नहीं वेस्ट करते हैं.
Yeah.
बस आई एम ऑन द जूम में आप क्या बोल रहे हो? शेयर, वापस शेयर पे जाना है.
शेयर करने के बाद में शेयर स्क्रीन में आप जाओगे ना, तो डू द शेयर वंस.
Don't know. It's not happening.
नहीं हो रहा है.
Something is wrong
There
with
must
my
be a
system. Anyway, I'll just
system
try
failure
once
होगा.
more and then otherwise,
ठीक है. No issues, ma'am.
I think something not been able to figure out. So the share is not coming on my this thing now. Rishikesh,
अच्छा.
yeah, I'll go to the share.
अभी आ रहा है मैम. Now you see in the top left में there is a home button.
अभी ये
And
दिख रहा है कि नहीं आपको?
हाँ अभी दिख रहा है मैम. We can see.
Scroll only there, na?
Ma'am, slide is visible.
ये आगे बढ़ रहा है कि नहीं बढ़ रहा है?
No, madam, it's not moving.
I think just something is wrong. Yes,
आप
sir.
या फिर F5 दबा दीजिए, कंट्रोल F5 दबा दीजिए
मैम,
स्लाइड शेयर करने के बाद में.
आप जो प्रेजेंटेशन, हाँ मैम, अभी जो आप प्रेजेंटेशन मोड में ना, उसे प्रेजेंटेशन मोड को एक बार बंद कर दीजिए, उसके बाद आप शेयर कीजिए, फिर शेयर करने के बाद प्रेजेंट पीपीटी में जाके फिर स्लाइड शो कीजिए, तब वो विजिबल होगा.
एक बार कीजिए मैम, रीशेयर जूम में जाके.
वापस से शेयर पे जाना है.
हाँ वापस से शेयर पे जाइए और F5 दबा दीजिएगा आप.
F5.
या F5 नॉर्मल और फंक्शन F5 इफ फंक्शन इज देयर. शेयर होने के बाद में. हाँ नाउ यू प्रेस F5 या कंट्रोल F फंक्शन F5 या ओनली F5.
Okay.
Try the both keys.
I don't know why it should happen that way. Let me just.
Okay.
Let's not get into this. I'll reopen my presentation again and then we'll try. If it works, fine. If it doesn't work, it's okay.
No.
Ashna ma'am, you can share your slides to UNS people. They can share.
That's what I'm going to do. That's what I'm going to do. So maybe, like you can start with the panel. I'll keep mine last because let's not. Because something has been happening.
Ma'am, you can share with us your slides. So
Okay. Okay, I'll do that. So which email address should I share? What?
I just texted you on the WhatsApp, ma'am.
Okay.
Or else अपना mail ID will
Meanwhile,
डाल
if there are any questions or anything, let's not. I didn't get your email.
मैं भेज रहा हूँ. I'm just saying. Done.
Thank you. Dr. Brejbala, meanwhile, like some.
Will I introduce the panelist and
Yeah,
moderator?
तब तक panelist को introduce कर लीजिए.
Okay. So, Bhakti, will you?
Yes, ma'am. Yes.
So we are having very excellent moderators, and we are having Galaxy of panelists from all over Pan India, Gujarat, Maharashtra, Bengal, Odisha, and UP from everywhere. We are having two excellent moderators, Dr. Mona Shroff and Dr. Ekika Singh. And Dr. Mona is past president of Surat OBGY Society. She is senior clinical director and national strategic director Nova IVF Fertility and president SOGS 2324. And she is master trainer of AMOG program certified by Zapaigo under Foxy ICOG, Government of India. And she has been associated with many colleges and trainings. And I welcome you, Dr. Mona, for this MP Chapter SR webinar today. And the next moderator is Dr. Ekika, good friend of mine, and she's from UP, Sharda Narayan Hospital, Mau, UP. She's managing director and had been awarded many times as champion of SR, Wonder Foxian, best paper presentation in SR, UP COG, and the Best Doctor Award by Lions Club International, and many publications to her credit. A poster presentation in ASHRAE, RCOG, and national and international conferences. And she had so many research work, roll up PPOS protocol, embryo glue in implantation failure, roll up PRP in thin endometrium. And she is holding the post of president of member of Mao OBGY Society and managing committee member ISAR, executive member UP ISAR, and so many credits to her credential. So I welcome both Dr. Ekika and Dr. Mona as moderator, and we are having galaxy of panelists. Bhakti, will you share? Yeah. So we are having Amrita, Dr. Amrita from Gorakhpur, and she is past office bearer of Gorakhpur OBGY Society. Will you share CVs of everyone? Yeah. So, Dr. Amrita is VP of Gorakhpur OBGY Society. She had been organizing secretary of workshop in Nazon Yuva Foxy.
Thank
And
you.
she's
Thank you, Dr.
yeah.
Brijwala, for having me here.
Thanks
Let's move
thanks
fast.
for joining, Dr. Amrita. Next, we are having Bhakti. Yeah. We are having Dr. Bharti Gayatri, and she is having certified course in OBGY under Dr. Sonal Panchal, and she is consultant high risk obstetrics and at Advanced Infertility Center. So I welcome you, Dr. Bharti. Next.
Thank you, ma'am.
Next, we are having Dr. Manjushri Boob. She is from Amravati and she's holding post in Amravati and she's known figure in ART and she has published booklets on PCOS and endometrium receptivity. And she's holding the Indo-German Test to Baby Center at Amravati. Welcome, Dr. Manjushri.
Thank you so much, Brijwala. Nice to have being with you.
Thank you so much for joining. Next, we are having very vibrant figure from Odisha, Dr. Sandhya Rani Panigrahi, and she is well-known figure in Foxy, and she is very active in ISOPA, Foxy, and IMA, and she is very good in poetry in Hindi and other languages. I welcome you, Dr. Sandhya Rani. Next is Dr. Kanchan Desle. She is from Nashik, but basically she passed out from Indore. So welcome Dr. Kanchan for this MP chapter SR. And we are having Dr. Amandeep Kaur from Jammu, and she is consultant at Government Gandhi Nagar Hospital, Jammu, and associated with IFS, IMA, certified menopause practitioner, and she's general secretary of ISAR, and she's gold medalist in her PG. So I welcome you, Dr. Amandeep, for this MP chapter webinar. Next. We are having Dr. Ojaswini Patel, and she's from Burla, Odisha, and she has been awarded with so many times gold medals and best graduate in MBBS, best free paper. So I welcome you, Dr. Ojaswini, to this MP chapter webinar.
Thanks, perfect.
we are having Dr. Sashmita Das, very active, very active Foxian, and she's past president Karimnagar OBGY Society. And she's senior research fellow chair 1988 and awarded with public awareness committee Foxy, and having so many publications, 64 scientific papers. So I welcome you, Dr. Sashmita ma'am, to this MP chapter.
That's it, ma'am.
I think.
Yeah.
So I hand over to our moderator for this important panel discussion, Dr. Ekika and Mona. Thank you so much.
Thank you so much for such a kind introduction for all of us. And I'm really very honored and humbled to be discussing this topic along with Dr. Ekika Singh and along with such an esteemed, panel of experts to guide us through the long process of, the red flags of infertility imaging. And I think Dr. Sonal has made some of our work easier. I'm sure Dr. Ekika will agree.
Definitely.
So probably she has set a very strong base for our discussion to carry forward in terms of case discussions. So in fertility imaging, unfortunately, what we miss once, the patient misses forever. We all maybe do some prayers while doing an embryo transfer that, this is the chance for our patient, and it is the culmination of the best efforts from our side and from their side and from our lab side. So, but still many a times we face patients where, we somehow feel कि कुछ miss हो गया क्या, क्यों नहीं हुआ, what has gone wrong. And a lot of statistics also says the same thing, that 30 to 40% of infertility causes are undetectable through the regular imaging, and by standard imaging they are missed. And 22% of these patients have imaging findings that were previously missed or misrepresented, and we come to know only after they have failures. And 15% of IVF failures are due to these some structural issues which can be detected but have been missed on imaging. Just a minute.
Yeah, and I just want to add, this is a very good presentation and a very good effort of Dr. Mona. She has really, even when I was going through and I was seeing there are so many things which we are going to learn from this. And it's a very interesting panel presentation with the very renowned panelists. So Mona, I think let's go ahead and start with whatever the objective and the cases we have.
So the objectives of today's panel would be to, identify those critical imaging findings that may predict a poor reproductive outcome, and probably we can give that one chance for many of our patients. Sometimes only one cycle of IVF is what they can go through. Learn through real cases with more actionable insights for all of us. Integrate the evidence-based imaging protocols into our clinical practice and how we can go about it, and to avoid the pitfalls. So I think Dr. Ekika, we all have been introduced.
So I think let us start with the cases and let's discuss the clinical tips and points so that we all can have a good take-home message. And and finally, with the imaging also, it's not only as Mona rightly said, the protocols which we follow, or maybe just the pathological findings which we get, or maybe just whatever we send for the test and we receive and we say, okay, this is the thing. Let's go beyond that and see how this a probe of ours can help us to know things which can help the patient. So Mona, please go ahead with your first case. Thank you.
So we'll discuss the first case. It's a 32-year-old typical PCO, delayed cycles. AFC is 35, AMH is high, 6.8, and on TVS it's a PCO morphology that we are able to see. But when we did an ICSI cycle, they were the eggs were of very poor quality, and our embryologist was shouting. What do you think? She's a young 32-year-old. So could we and can we, can any of our panel enlighten us on, is there any way by imaging technique that we can identify cases which are more likely to have a poor oocyte quality? Anyone who wants to take the question? I think it's an open panel, so anyone who would like to share, we can.
Yeah,
High stromal flow is there.
Yes.
Dr. Sonal Panchal ma'am has already discussed in detail about the stromal blood flows. So, especially in cases of PCO, we should always do Doppler to see the stromal blood flow. Because if it is very much high central stromal flow, we can have hyper responder risk. But if it is very low, we'll get a poor responder also. So we should initially do stromal blood flow, both thecal and central, in cases of PCO especially, so that we can tailor-made our stimulation according to that. And also avoid
I would
OH.
Yeah. I would just like to add, like, apart from this, doing a first day Doppler, along with a routine transvaginal scan, this will help us know that this is a type of very resistant type of PCOS. So here, just don't go away with your protocols immediately. Have lifestyle modification, take charge of the patient, and then only you should proceed with the cycle. It may take 2 months, but I think if we can take charge of this stromal blood flow and take charge of PCOS, we will have good results and good quality of oocyte. That's a practical point.
True. So thank you, Dr. Manjushri. And I think a very high central stromal blood flow does have a very high response risk, but it strongly correlates with the androgen excess morphology of the PCOS. And that is the reason. So probably we can, as ma'am rightly said, we can treat them with metformin and antioxidants
Body
treatment, and then
lifestyle management, right?
Along with that, we can shift to IVF at a maybe because she's young, 2-3 months waiting may not cause an harm.
So, as it is said, the stromal flow, I just want to add one thing. Even besides Dopplers, on 2D scan, if we see a big ovary with a big stroma and the peripheral distribution of the follicles and increased stromal thickness also, that also relates with the increased LH levels. And then that can also cause the poor oocyte quality. So even in these cases, with the lifestyle modification and metformin, sometimes ovarian drilling also help us to, tamed out the tonically raised LH and then can help us to give a good quality oocytes in these patients. So this is one thing for PCOS, which we call it as a good PCOS or a bad PCOS. Bad PCOS are these ones having multiple follicles, still not getting anything. So these are the things which can be tried in them. So that brings us to our second case, and she is a 30-year-old female. She has a history.
Can I add one thing about PCOS drill?
Yes,
Better have AMH level. If AMH is 7 and above, like in this case, you have AFC of 35, AMH of 6.5. This is a right candidate for metformin, lifestyle modification, maybe cyprotrione acetate and drilling. All four beforehand, and then she may conceive with even IUI if tubes are patent. So, or IVF depends on the case.
I think in era of IVF, drilling should be kept reserved for very resistant cases, because we can lose normal ovarian reserve also.
This is a case in which we are getting bad oocytes quality. So when you are getting a bad oocyte quality in a patient who is a PCOS, so that is the time when we can think and can give a finishing touch of deciding that individualized by the patient cases. There are the cases where we can do. You are absolutely right. In era of IVF, we generally don't for ovarian drilling, but when you get even bad oocytes in them, then you can think of some other options to give her good oocytes. So that is where it can be individualized. Thank you, Amanti. So this is one case in which she's 30-year-old with a history of early pregnancy loss at 8 weeks. Suction done. Now she's having secondary infertility for 3 years. Endometrium thickness is 5 to 6 millimeter at time of ovulation, and hysteroscopy is normal. So, what do you think? Are there any red flags in this, or is there anything which you would, try to look for before going for anything for her? Normal induction
May
or
I take this? May I take this?
Yes.
Yeah, for in this patient, as we see that the endometrial thickness is quite low, it should be at least 8 at the time of the ovulation, and a good endometrial flow also. The blood flow should also be good. It should be a 3 laminar shape, 3 laminar, and the volume of the endometrium should also be good for a good receptiveness. So we should even look for hysteroscopy was normal, so I didn't talk about the Escherman and the polyps, etc., the structural abnormalities. But yes, regarding the blood flow here, the 3D Doppler would help, and the watching the uterine blood flow would help in such cases. And endometrial thickness is definitely low in this patient.
Anyone else want to add anything?
Like to add, like if we see the endometrium, there you can see some fibrous line in the middle, which is slightly more echogenic. So maybe after the adhesion doesn't form in a day. So before even forming adhesion, there is an endometrial irregularity. There is a vascular pattern which becomes bizarre. There is endometritis leading to fibrosis, leading to adhesion. So definitely, if we catch up early, this adhesion before the thick synecdoche develops, that is a time where even hysteroscopy will have only flimsy adhesions. It's not the very stage 4 adhesions which are there, Escherman. But if we see even some flimsy adhesion which are present at the cornea, we should know that she is a case of Escherman and we have to remove it and treat endometritis also at the same time.
But the hysteroscopy was normal. So that's why, I mean, Asherman.
Yes, Dr.
We can. Okay.
Junction is a very important entity. We should look at endomyojunction also. That can also cause problems.
Yes, yes. That is true.
Yes.
Basically, I would like to add. So basically, in this case, our day 2-3 scan becomes very important. And since we are using all ultrasound, and if we have a 3D ultrasound or stepwise evaluation, that is a good 2D. Then if we don't have 3D, a good SIS, if we can, and then a 3D where, as ma'am mentioned, that we can have a good assessment of endometrial junction evaluation. And this hysteroscopy sometimes can confuse, as ma'am said that initially, sometimes you can't see very flimsy, but if, in the 2D scan, if you see mild irregularity of the central line, it sometimes portrays towards, because this important finding is at the time of ovulation, endometrium is just 5 to 6 millimeters. So always taking care that the history is there of DNC, we should always think of adhesion as the primary cause. The secondary cause can be per se chronic endometritis. So first is the adhesion, second is chronic endometritis.
Anyone else want to add something?
I would like to prefer us to give PRP also at this.
Dr. Majushree, you said something.
Yes, I would like to add on PRP at the sitting of hysteroscopy also, at the first sitting only. If your endometrium is not growing at the periovulatory phase, if it is having some white line in between, if vascularity is not good, if subendometrial vascularity is not perfect, I'll keep a PRP ready and will give hysteroscopic PRP also at the same sitting, rather than putting her for another second or third hysteroscopy, even if there is no adhesion. Because see, the pathology is in the endometrium. She's ovulating, endometrium is not working well. And we have a very good novel modality of PRP, which works very nicely. So definitely at the first sitting only, I'll give PRP. Even if adhesions are there, I'll remove the adhesion and do PRP. And that too hysteroscopic subendometrial PRP at the basal level of endometrium.
So
also, progesterone should be added, ma'am, and the good corpus luteum should be seen. The ovaries should also be assessed in such patients properly. If the corpus luteum is good, the vascularity is there in the follicle, the perifollicular.
Actually, what Dr. Amrita is trying to say, I mean, when the follicle is growing and if it is a dominant follicle, we are seeing there is a good flow around the follicle. Endometrium also start growing with the dominant follicle. So if it is not growing, this is one clinical sign which we can see. we have a dominant mature follicle with good flow and still endometrium is not growing. So in that case, we can always think of there is some kind of infection addition or a sign of endometritis in the endometrium. Otherwise, as the follicle grows, secretes estrogen, it works on the endometrium and the endometrium grows. Our point is, there are cases in which even with the hysteroscopy, we see that everything is normal. We see that, okay, I mean, by eyes, we are saying we don't see the addition, but still we are having problem. So in such cases, this could be functional impairment. That is what is meant by
one thing
this.
is that, one thing is that
could be
though
functional
here it is
impairment.
suggestive of the thin endometrium, but as because she's having some intervention in the form of DNC, so and having a long period of secondary infertility of 3 years, so you should also evaluate tubal patency test as a routine here also, along with the evaluation for the Asherman syndrome.
So
we know, please.
There was this one very large data presented last year in ESHRE that irrespective of the endometrium, they went ahead with an embryo transfer and the results were equivalent. So if there is a good vascularity, even with thin endometrium, there can be a good implantation. So many times we have seen very thin endometrium. I have cancelled an IUI and then still the patient conceives. So sometimes it's more of the better vascularity than the actual thickness that may help. And this is something called as a functional Asherman syndrome, as Dr. Ika said. So it may not be apparent on hysteroscopy, but if there is a functional impairment which can only be detected on imaging with a Doppler. Even a 2D Doppler is sufficient enough to identify the perfusion defect. And as everyone rightly gave their experiences, like a PRP or vitamin E, pentoxifylline, which can lead to more angiogenesis, can help in these cases. So beyond Asherman's, there's something which always harasses us or stresses us a lot, and it gives us a lot of sleepless nights, is a recurrent implantation failures. And especially when, in spite of doing everything, euploid transfers, PGT, everything, and still there is a failure. It leads to a lot of emotional burden to the patient, a lot of financial burden, and a lot of stress to the treating doctor as well, because you are the one who are going to counsel them about, and they rely on you or they trust on you for what to do next. So with that background, let us come to case 3. She's a 35-year-old, 4 euploid blastocyst transfers with a normal endometrial thickness, a normal hysteroscopy. ERA was done, which was receptive. Her metabolic autoimmune workup was normal. And are there any specific imaging signs which you would want to look for before we still have 2 more euploid embryos with us for her? So what would we want to do further for this patient?
These are the cases like Dr. Sonal Panchal just mentioned, that we have to go beyond endometrial thickness. We have to go for endometrial volume. Endometrial volume in 3D Doppler we have to see. And if it is less than 2 ml, we have again chance of implantation failure. So we have to do endometrial volume, which is very, very important apart from the other things like flows and all.
I would like to say that be critical on yourself now. The 7 pillars which are given beautifully, which I just read because of Dr. Ekika and you all, and that has really opened eyes that we need to work very diligently. Firstly, see in the cavity. Secondly, see in the endomyometrial junction. Thirdly, see in endomyometrial junctional vascularity. See for peristalsis. See for any space occupying lesion. See for endometrial vascularity and Doppler. It was really amazing reading all this. And I must thank, or we all must thank Ekika and Dr. Mona for making us read on this. And I think even this endometrial morphokinetics, this is also so wonderful. We all will have increased success rate. We may reach up to 90-95% now with all this.
Ma'am, I just want to give a disclaimer. This is beautiful hard work of Mona. She has done everything. I just have put one or two things maybe, but I, in front of everyone, even wants to thank Mona because of you. I also came to know many things which I have really read also.
Yeah,
And definitely
seriously,
her.
it was absolute new to us. We were
Actually,
doing
it's
it
quite new to me.
practically. We were doing it practically, but all things which has been put together as seven pillar. It's a really a wonderful thing, and we need to put this slide in front of your ultrasound machine that you have to work this way.
Thank you so much.
So this brings us to the next case, and she is Mrs. D. She's 29. She had two implantation failure with two miscarriages at 5 to 6 weeks, associated with pain and expulsion of the sac. Normal karyotype, no adenomyosis, thrombophilia negative, antiphospholipid negative. So now what? The patient will come to us with a question, Madam, what to do now? So it's now our onus, and there are things. Are they really important? That is what is I would like to ask you. Anyone who has worked on this can say about the uterine contractility. So,
regarding the uterine contractile mapping, so it is very nicely explained, and we are just going to repeat the same thing, that we have to look for four things. One is that what happens is either there is hyperperistalsis. So normally what we expect is that 2 to 3 contraction per minute. This peristalsis is normal, but if it is more than that, so for that we have to, like a hawkeye, wait and see this peristalsis. Sometimes, take this in a loop and assess. If it is more than 5, so we consider this as hyperperistalsis, and the typical direction is towards from fundus to the cervix. So a kind of expulsions. That is why this patient is having simultaneous painful expulsion. And then it has a certain amplitude also. So hyperperistalsis on one side, it is not good. It is leading to the implantation failure. And on other side, there is hypoperistalsis, where actually it is so less than 1, it is not allowing the proper implantation to the right side. So it is not allowing the embryo to reach to the right side. Then there can be disharmony, dissynchronous of the thing. I think it is very difficult to see, but this might also happen, and it is actually happening if simultaneously somewhere in the endomyometrial junction on the myometrium, sometimes if some pathology is there leading to hyperactivity, vascularity, abnormal vascularization, can also indirectly affect the peristalsis part. So there is dysynchronity. Then there is, when there is sometimes adenomyosis. So focal surgery is being done. So there can be a peristalsis. So these all, the peristalsis part has been beautifully taken up, and this is leading to this condition of, implantation failure and miscarriages. So 4 factors basically.
So
to add, for this, you just have to take your real-time transvaginal scanning.
Yes.
Just put a TVS, take your uterus in the center with the endometrium in the center of the screen. Just be there and observe, like you observe your lover or your best friend. So put your eyes there in the endometrium and just watch the contractility. We are in so much hurry that we just put a scan TVS probe and just move away. Yes, endometrium is there. There's good vascularity and done. No, don't do that. Real time scanning, and this muscular contracture or the peristalsis of endometrium is little bit more different than peristalsis of endomyometrial junction. These two need to be seen very carefully, and we need to work on it. If you do 10 scan, there will be 2 or 3 cases where there is hyperperistalsis. In that, if you give etosaban or some uterine relaxant, that is really going to improve the success of your IVF cycle.
Yes, as rightly said by Dr. Manju ma'am. So in hyperperistalsis, if we have really found, then etosaban is something which many a times it is being used in IVF centers, very infusion specifically in such patients, or nifedipine can also be given 1 to 7 days post transfer 10 milligram. And dysynchronous waves, if they are there, then the progesterone injections in the high dose, they also say that they can lead to coordination. Generally, progesterone is the soothing agent which is being given to soothe them so that there is a good implantation. So whenever there is a dyssynchrony, progesterone will definitely help to calm those waves and can help us in, giving a good result for these patients. While doing the transfer also, sometimes it is seen. There are patients in which you can see that, yes, it's difficult to transfer because you enlarge the endometrium so that you can transfer, and that is the time when you can really see that pulse and waves which are going. So assessing them is very important, and notably want to say it is not for every patient that we see this, but yes, for us it's an every patient, for her it is she only. So that is how we have to understand and take care of these patients who are having RAEN. And I think Mona, rest please, you if you can
Sometimes it happens that we don't have time, but any good assistant, they can just take the recording for 5 minutes in the sagittal plane. And then because it's a very slow wave, normally in normal 1x speed, it is very difficult to pick it up. So after recording, we can just put it into 4 times the speed, 4x speed, and then immediately you can recognize the pattern. So for us, it is just 1 minute because a 5-minute recording, we can just see in 4x speed, maybe 1.5 minute, and we can judge the peristaltic abnormality, and extra 1 minute, 1.5 minute for us. So I think it can be done with the intention and in the necessary patient, as Dr. Ekika said, we should be doing it.
So for me, this thing is new, but for like progesterone, we are already giving precautionary. So I just have a question right now that what kind of progesterone? So we are like promoting the micronized progesterone or the digesterone. Which one is going to be more helpful for this?
So for usually like standard dose, if you're only any 2 modes, I think are more than enough. So either a vaginal plus dydrogesterone, proper full dose, or a vaginal plus injection, or a dydrogesterone plus injection. So if 2 routes are more than enough to compensate for the dysynchronous waves, I feel.
And Bharti, as such, I tell you, because at my center, at our center, before the transfer for 6 days, we just give injectable progesterone, and we have taken the values also. So once you start the injectable progesterone, the progesterone value are pretty good. So pretty good. I mean, sometimes I have seen it is going till 40 also. So that much of progesterone is enough to calm and take care of this dyssynchrony. So probably injectable progesterone alone is quite sufficient, which can be done.
Yeah, practically, I generally give etosapan and progesterone combination just half an hour before a embryo transfer in this type of patient. Just give half an hour before so that our quiescent is maintained and we have a better embryo transfer and a implantation rate.
And especially so when it's a case of adenomyosis, where I think it gives a very good.
Yes. Agreed.
And
please, Mona, if you can explain.
Sonal has already, talked about all the VI and VFIs, but anyone would just like to quickly, just update about the endometrial pattern and vascularity.
I think we all are clinician, not a Doppler specialist, so it's very difficult to go.
We can just keep this as ma'am rightly said, that we can keep this in front of our ultrasound. If we are doing our own follicle scans, I think this may help, because if it's there in front of us, we can just immediately, it doesn't take time to just
see and do it.
And there are most of the ultrasounds will have, like, we can request the person to do the settings as per our need, so that many a times it doesn't take time. It comes as automatic, the data. So the PIRI, everything will come automatic. We just have to put the Doppler. So again, this was nicely described by the branching angle and the vessel density by Dr. Sonal. So I think we can just skip this. And management for vascular abnormality, I think we all have been doing this, but anyone want to just any inputs on this? Like if there is a hypovascularity or
Whenever, if there is hypovascularity, then we prefer something which is improving the, blood flow. So sildenafil we are using vaginally, which is to be used 25 milligram 4 times in a day from day 1 to day 14. And even again, we like use of aspirin holds the same thing, that improving the vascularity. So 100 milligram. Then other are means I don't know whether any role of pentoxifylline or other tablets for that, but it does show improvement in the pregnancy rate by improving the flow.
We should not forget the lifestyle changes, etc., and avoid the toxins like alcohol and smoking if we want to improve the vascularity anyway.
Give
Arginine
arginine
sachets are
sachets
very
also.
good.
Arginine sachets also we
Yeah,
give in
arginine sachets
arginine.
are very good. Along with that, heparin, low molecular weight heparin. So all these four together, like aspirin, sildenafil, SOS, but LMW definitely yes, and arginine definitely yes. In case where you see that perfusion is not up to the mark, you are not going to transfer unless and until perfusion is superb. But like sometimes you have cases where you have good vascularity, but not very good. So in that cases, you can add all this four and then do a transfer.
And
On the
once we
same,
start
same
doing
cycle
the
or the next
Dopplers,
cycle?
yeah, and when we start doing the Dopplers, if I give, say, low molecular weight heparin for 3 days and I redo the Doppler, those are the cases where, we get also the confidence in which drug works the best for that.
Yes. Yeah.
This was also like, something new for me also, because when I was reading through to prepare the panel, I was not aware that there were things which we can, even the immunological interface can be, detected on the imaging. But although there are some special imaging required for this, so the contrast enhanced ultrasound, elastography, which is right now not very popular or available, but probably it's the future where, these will be the things where, we don't even need to do too many other invasive tests, and even a simple contrast enhanced ultrasound or things will tell us a lot about immunological interface as well. And there is even a scoring system where the endometrial edema, the microulceration count, and lymphoid aggregate density, the vascular permeability, which will tell us about an abnormal immune profile, and accordingly then we can treat those cases because right now we seem to be giving a lot of empirical therapies for immunology because we don't know like which immune pattern needs which therapy. So most of the time it is the cocktail that either the labs recommend or the reproductive immunologist recommend. But there would be a day when there will be very specific treatment for very specific abnormalities.
Anybody has used,
Yeah.
hello?
Yes, Dr. Kanji.
Anybody has used the tracolumus vaginally one daily for 14 days and seen the results?
We have used a lot of oral. Vaginal we have not used.
Okay.
Oral we have used in a lot of cases because we do get a lot of failure cases from everywhere, all across Gujarat, and we have to then evaluate and go a couple of steps further for them.
Okay, thank you.
So basically, in this case, the assessment of vascularity is very important, and people have started working on this already in recurrent pregnancy losses, where we have this antiphospholipid syndrome. So they are this new ultrasound microvascular imaging. So they are using to assess the radial artery for the kind of flow. So now the time has come. Now people are looking into era, which is the day 1 to day 14 of the IVF cycle. So this is going to be very helpful. The assessment of vascularity and the edema and all these new microvascular imaging. So this is going to
So
be very
really, it
helpful
is
now.
very wonderful presentation. Huh? It is very new things we are getting from this
Yeah.
all presentation.
Thank you. I'm sure all
Yeah, wonderful. Hello.
and getting so much of input from so many experienced people, it's making it more valuable.
Definitely, after attending or be a part of panel, we are wiser tomorrow in our OPDs to treat our patients of IVF and infertility in toto.
So there is this again RIF scoring system which we can start using, at least part of it, if not fully, to help improve, because there would be like low risk cases, moderate risk, and then targeted interventions as per the risk factor. And if the RIF scoring is very high, where all the parameters, all the pillars are in poor sync with the outcome, early advice or counseling them for surrogacy would be a wiser thing rather than giving them a lot of heartbreaks. And because early pregnancy losses and recurrent miscarriages, more so with recurrent miscarriages, early pregnancy losses, it's actually very heartbreaking. And I have seen, like, one of my very close friends also, I've seen them going into depression and a lot of things. So when we are very clear about our guidance to them, I think it may help us prevent a lot of heartbreaks. And many times, like additional use of MRI, many a times we don't have radiologists who are who can pick up the nuances of the MRI. So when I was the president in Surat, we had a radiology and gynec combined on non-ultrasound imaging. So we had a very vibrant discussion on role of MRI and CT scan, and like probably they taught us some things and we taught them what we want from them. And it was really very helpful where, because they don't understand what we need. So sometimes they just give a very standard MRI report, and probably what we need exactly, the junctional zone and everything, is not very clearly. I think ma'am's lecture on adenomyosis and endometriosis were there, so we didn't take the case of adenomyosis. But anyone want to, because many times we get reports like it's an adenomyosis. But what specific thing would you want either the radiologist or the MRI person to share with us? So what would you request them that we want this findings in an adenomyotic cases?
Whether it is a like a pan-uterine disease or it is a localized, focalized disease, that is very important. If it is only in posterior wall, quite away from endometrium and not involving large part of endometrium, it's okay to go ahead. But most of the cases, it is a globular disease, like whole of a uterus is having with a very bad endomyometrial junction. And here you won't get a trilaminar endometrium. But when you put color Doppler, you will see that vascularity is there. So here a confusion lies that is not a proper trilaminar, whether we need to put an embryo. So these are all things that we really need to ponder a lot before embryo transfer. Better to treat this type of irregular endometrium or a bad endomyometrial junction with GnRH agonist for 3 cycles. Let her have a cycle after that on her own, which may take another 2 months or 3 months. And then when you see this endometrium with your HRT preparation, if lining is very good, then you should plan a transfer rather than just making an embryo and next cycle or third cycle transfer. Think on endomyometrial junction a lot in cases of adenomyosis or all the cases of IVF cases. Before transferring, you have embryos with you, which are very good. Before transferring, you should be 100% sure that your endometrium and surrounding structures are very good. That is like my practical take on this.
Very important.
And any role of hysteroscopy in such cases, any experiences?
Yeah, you may find some endometrial cyst, a small collection. When you put a scope and when you see some bleb-like structure, you open it, you may get the chocolate color fluid also from that. So that may be there. An irregular, ragged endometrium, patchy endometrium. Because see, it do has a endometritis.
Chocolate endometritic cysts, no? Then I think if we have a good ultrasound report, we can try to, excise or remove all of them. It
Yes.
does definitely help a lot in, preventing especially the miscarriages even.
And inflammation is a part of it. It is the inflammation fibrosis which is causing bad endomyometrial junction rather than endometrium going anywhere. So how long is the disease and how is the vascularity and how many fibrosis is there? This all will be better seen in your ultrasound, transvaginal ultrasound rather than hysteroscopy. So, like, because disease is going from endometrium to myometrium, but implantation and vascularity to baby will come from myometrium to endometrium. So, we have to work up that zone properly.
In this,
We
hello,
should not, hello, we should not
hello.
forget the tubes also. The
Yes.
hydrosalpinx, if anything is there, it would lead to toxic substances secretion and lead to abortion even if we do an embryo transfer. So we should not forget about the tubes.
Mona, hello.
Yes, yes, ma'am.
Have you used Egolix or Anagolix for endometriosis? Is
Yes.
there any?
The advent of Egolix, no, I've stopped using injectable.
Even we have
Same. Yeah.
Because I had a good experience when my patient is conceived with the Egolix with the severe endometriosis. So big chocolate cysts were there, and she conceived with first cycle only. So I'm happy with that drug. So I want to share my experience.
Okay, that's good.
Same here.
Here I would like to add that
Continue till
in such
the
cases,
endometrial scan, even for frozen transfers, no, I continue Egolix till the day of, till before I start the progesterone.
Okay.
So it helps in reducing the inflammation and premature progesterone elevation, everything.
Okay.
so here I would like to add that in such cases, because there is mostly association of endometriosis, and you will see the shape like retroflexion, the presence of S-shaped cavity, and then this external adenomyosis, which is, when the endometriosis is adherent from outside. So that leads to, the change in the whole morphology of the uterine cavity. So that is also important to see. And then obviously, as ma'am said, the presence of hydrosalpinx. So that abnormal fluid can sometimes, will fail our IVF just because of the toxicity. So that is also important. So a deep assessment.
Like we always think about a communicating hydrosalpinx, which is leading to fluid. But there is a lot of data where even a non-communicating hydrosalpinx, even after
Yes.
it leads to a gene modulation in the endometrium.
Yes.
So the OXA10 gene is downregulated. So there is some research which says that it is better to remove the whole tube rather
Yes.
than just delink the tube.
Same thing if the laparoscopy you are doing for laparoscopy, you can clip if the hydrosalpinx is there, so better results will be there.
So
sometimes it is silent hydrosalpinx. When you see during day 2-3 scan, you won't see anything. But at the time of ovulation, sometimes you see, swelling of the tubes. So that is when in the next cycle you can plan. Like when we are doing our day 2-3 scan, you won't see any swelling. But later on, sometimes you see fluid. So then we can.
Yeah, but as such, whenever we are seeing a hydrosalpinx, even all the recommendation says it is better to do salpingectomy. Clipping, I think, only in those cases where we really find it difficult to remove the big one and it can cause injury to the other structure, especially the bowel and all. That is the only time when we really try to clip them and leave them. Otherwise, as was Dr. Mona said, it really lead to, some changes in the gene expression and can cause problem. So it is always good to do remove than to just clip. That is what I just want to say. Until and unless your surgery is so difficult that it can harm something. Sometimes with endometriosis, specifically grade 4, it is so deeply embedded and adherent to the sigmoid and the rectum. So clearing all of that, but I suppose with a good surgeon, I mean, who can really too good in laparoscopy, then really can start to remove delink. It's always good to do salpingectomy than to do delinking when we are doing anything for the fertility issue for the patient. So that is what I think everyone agrees with this.
Yes, yes, yes.
I think Mona, you can go ahead with this case. Because
Yes, so she's a case of chronic pelvic pain. There was no, she's 32. There was no endometriosis on laparoscopy. Hysteroscopy was normal. So unexplained infertility with chronic pelvic pain. ICSI was planned, but there was a slow response twice. So the eggs developed lesser than the antral follicle count, and they develop like conventionally our stimulations go for just 9 days, and they are ready. And this went on for 13 days, and both the times it was negative. So any red flags that we should look for in such cases?
This is a case of chronic pelvic congestion. And what we get to see is the ovarian vessels, etc. There is congestion in the ovarian veins and the uterine veins, the parauterine veins. There is congestion. There is slowing of blood flow. So that is all we can see when we put in the color Doppler. So yes, the vein diameter is more. The valves are poor. Reversal of flow is there. Yes. So all this can be seen.
And what could be the likely mechanisms how this can lead to a poor, slow ovarian response or an unexplained infertility?
It is quite similar to varicose veins in your legs. This is a varicosity of pelvic vein. So as you get calf cramps, why? Because there is a presence of more toxins, venous circulation is decreased and it doesn't take up. At the same time, arterial circulation is also coming very less. So at both the end, there is a problem, varicosity, because of this venous vascularity, because the perfusion from or detoxing material from the pelvis is not going as fluently as it should have been gone. And at the same time, even the perfusion factor is also defective because a problem lies in the intima of the walls. Not only veins, it is arterial disease also.
And probably there have been a lot of cases reported where, embolizing these vessels, especially when there are broad ligament varices also, but then ovarian vein embolization before stimulation has shown to improve outcomes, and many of them have even conceived naturally after that. When we talk of pelvic congestion, no, sometimes there are it may be associated with endometritis, which in India we see a lot of cases. So I think Dr. Ekika can take this up.
You are muted, Dr. Ekika.
Sorry. About the pelvic congestion syndrome, I just want to tell about one of my patient. Very same case. I mean, she was conceiving RIF and maybe abortion at 6 weeks, 8 weeks. She did give us a history of dyspareunia, but it was not that it was very prominent. Yet once again, she also spoke. I want to tell you because this I missed. That is why I'm telling you. Twice I missed, and the third time I did her transvaginal scan because this was a third time or maybe fourth time I remember, and I did it along with my ultrasonologist. He was there to check it, and then we could really see a engrossed ovarian veins. So I was like, what to do now? We don't have that embolization facility at my center. I went and read through this. And then, like, you can give suppression, hormonal suppression also, and then try again. So what I did, I gave her GnRH agonist for 3 months complete. And we again measured the vein diameter after that. It was reduced. And then we did her transfer, and she was positive. So in her case, didn't know what is the reason why she is like it's happening to her, and this is how it came up. So pelvic congestion is something which we then from then onwards I actually look for it for every even first patient who didn't conceive. If I have taken a good endometrium grade 1 transfer done very nicely and she has not conceived, again I would like to see and ask her again and again. Embolectomy is the treatment when the medical management fail, but giving even simple overall L kind of a thing for 3 months continuously will also lead to reduction in the size of the vein.
Yes.
So that is how, these patients really conceive well. And now presently, I'm so happy that she is now having her twin pregnancy, and she's 6 months pregnant. She's going
Actually,
well.
high estrogen is responsible for this, the increased vascularity or the congestion, the
Yes.
high estrogen levels. So what you did was right, that you gave an agonist which suppressed the estrogen levels. So
Can you give progesterone as well, Dr. Ekika?
Yes.
Because I have
Yes.
tried sometimes giving
Yes,
the
ma'am.
progesterone.
Yes, ma'am.
That
Yes,
also
ma'am.
Like in
reduces.
It
cases of
helps.
AV malformation, we first do medical management only. Any kind of AV
Yes.
malformation, is it working like that only?
Yeah, actually, that was the first case for me, and I really found that it is effective. It really had a wonderful result. So, and these are the things we sometimes miss. And there comes the chronic endometritis. This also, I think, most of us really face. Why do we face? Because I don't know in the other areas, but when you come to UP site or this site, endometrial tuberculosis is still, I can say endemic over here. So many a times everything is negative. You do things, okay, nahi, ye negative hai, but when you put your scope inside, you will find tubercles. You'll find it is there. So this is a very right word written, a silent killer. Not only of the implantation failure, Dr. Anuradha Khanna, who was HOD of Banaras Indian University, she had a beautiful paper in which she had, when they have done, PG under her has done a thesis, in which she said ki she had a patient who had a normal delivery. One normal delivery, when serious, and then sequentially she had, started having abortions. One IUD at 7, then 4, then 5, and then later on, she was not able to conceive. So she was a typical case of pelvic tubercular endometritis. So tubercular endometritis, one of the signs of chronic endometritis, is really one silent killer. Having said that, everyone, we do have the stats in front of us. Like 56% of women with RIF do have CE, and 42% of unexplained infertility cases also might have, and then there is a reduction in live birth rate. Sometimes it is missed on hysteroscopy, so that plasma cells on histology is something which we do. We generally, actually, abhi to many a times, this is what everyone used to do, but now with the lecture and the coming slides, we all will start looking for the rest of the things also. So once again, I really want to thank you to bring this topic and then to elaborately tell about all the features, which I really want you only to tell, because this is what you have researched and you know it better than me.
In plasma cells also, no, like I've always had a lot of debates and discussions with pathologists, but there is a lot of gray zone there also. So no one knows like what percentage of plasma cells would be diagnostic, what would be a in between area. And many times, we don't get accurate reporting. So there are like endometrium panels now available. There are many labs who are doing everything. They do the uterine natural killer cell, the plasma cells, the BCL6 and everything. But still, I could not get, with the amount of patients of tuberculosis that we see, it doesn't correlate with the reports many a times. So what we see on either lapro or histo or other findings, many a times it doesn't correlate. So depending on pathologist, rather than that, I think depending on self and our machines would be a better option. So can anyone just briefly describe like what are their experience regarding infections in the pelvis when you look at the scan?
Most of the times we see a persistent fluid throughout the cycle. Very thin, but it keeps on persisting. That is written here also, but we see it many times. Yeah.
That
In
is
my
most
case,
important.
basically,
And also,
sorry, please, you continue.
and also we many times we see microcysts also in the
Yes.
endometrial near subendometrial cysts are seen, and fluid is seen, then we can always suspect endometritis.
Even the prebiotic can work better nowadays. Everybody is giving prebiotic. That is also good. Yes.
The
When
commonest
you do a
finding which
transvaginal, yeah, but please carry on, madam. Amrita ma'am, please carry on.
Ma'am, we usually see most of the cases of infertility, the endometrial polypi we see quite often, and hydrosalpinx and fluid in the pouch of Douglas is most often seen in our cases. And we usually, when we do a laparoscopy or a biopsy, we very commonly get cases of tubercular endometritis or tubercular findings. They are very common.
Especially with hydrosalpinx, then tubercular is very common. But otherwise, also in the absence of dilatory tubes, we see many times thin fluid which keeps on persisting.
In addition to this, I would like to add, like doing a transvaginal scan, which is painful. When you enter cervix, you will see a nebuthine cyst, which are very, very big sometimes. Thirdly, when you see the endometrial, you will see the irregularity, some very different type of appearance and very bizarre vascularity. When you put a power Doppler, ideally you should have vessels which are coming at right angles and like this. But in this, you will have some very different type of vascularity. Vascular indices we don't do, so difficult to comment on it. But at the same time, sometimes along with hydrosalpinx, you will have loculated ascites, a small pocket of ascitic fluid which is persistently there in 2-3 cycle, which suggests indirectly it could be a tubercular ascites. So I think these are quite many things. And secondly, uterus may be very fixed also, to maybe posteriorly or some side. So adhesion also you can feel, and which are tender also.
So I would like to add that in the day 2-3 scan, basically, a good 2D. And when we looking at the 2D, the heterogeneity of the endometrium, presence of microcalcifications, and sometimes the again like a Asherman irregular endometrium. Then very beautiful role, Dr. Ashok Khurana has written a paper on tuberculosis, role of, means effect of tuberculosis on the uterus and endometrium, and he talks about the 3D scan, where you will see, shrunken uterine cavity. It will be like a tubular cavity or, small shaped cavity. And a typical feature of your endometrial myometrial junction will be abnormal. There will be, changes in that junction and sometimes focal changes. And a typical, if you see the cornual end, it will be vertical orientation of the cornual end. So he talks about the features of tuberculosis by looking deeply into the 3D scan and in 2D. And then another thing is the color. And in color, typically in the day 2-3 scan, if you see subendometrial vascularity. Otherwise, these vascularity, they start at the late proliferative phase. But if you see zonal vascularities or abnormal vascularity, that is another feature of chronic endometritis present in the uterus. So these findings help. And later on, we can do other tests.
And many of these findings have more predictive value compared to even histology. So something which we can, do. Many times we know that there's something wrong. It's an instinctively also know that the endometrium is not good, or the pelvis looks inflammatory, or it doesn't look. Sometimes, like in my experience, there is one pattern which I see a lot. It's a fern-like pattern. So it's the endometrium normally doesn't look triple line, but it looks like a fern, and with micropolyps. So it looks a little thicker than the usual endometrium. And those are the cases where I've seen a lot of correlation with hysteroscopy, micropolyps, and biopsy suggestive of tuberculosis. So
in ovaries, if the follicle, edges of the follicle are hyperechoic.
That's
so
also
they point to
yes,
the presence of tuberculosis.
They respond poorly to stimulation also.
Absolutely.
Able to see
Once
the
you has
follicles, but they don't grow.
They appear quite irregular also.
Calcified follicles.
Calcified. So Mona madam, can you tell about the embryo glue you are using?
Yes, we are using, but not for all. Like most common indications are unexplained failures, or previous ectopic pregnancies, or if there are very low number of eggs and advanced stage, low number of embryos and advanced stage, we don't want to take a chance in those cases, and in endometritis cases. These are like the 4 or 5 indications where we use, and we have maybe 15 to 18% higher chances of implantation, I can say.
Okay. And actually, I have a paper because we are working on it, and we are about to present about the role of embryo glue in recurrent implantation failure. And when we started using embryo glue, and we were actually, I thought, ki, yeah, this is something which is giving us increase. But to my dismay, when we were doing the statistics of all of that, there was not very significant difference that was they see. There was some in few cases I could see. I have not summarized the whole of the thing. So probably it's only actually we started doing everyone with 2 failure, everyone with 3 failure also. This is how we did. We did it for both the patients. I mean, the self also, and even for the donor cycles also. So in that cases, we have seen that with the embryo glue helped in the patient with the self transfer and more than 3. That is what, and though the difference was not very high, but some significant help was there in after 3 RAI failures. So embryo glue as such, I mean, the stats of we have done near about 110 patients, we have compared it. So stats doesn't say that it is very good, but yes, when a patient conceives with embryo glue, for them, it is very good. That is what
Very
I want to
nice. Very nice.
Counseling, I think, is important because they feel that it's something magic, and
yes,
we
that's
do
what.
counsel them that it may increase the chance by maybe 15%, which is a good
Number.
percentage for them. But then it's not like if the embryo itself is not healthy, obviously the
Yeah, you will not get it.
may help.
Yes.
So what is the difference? PRP is better or glue is better?
Both have different
different
mechanisms
modalities.
and different indications. So I think both. Sometimes we use for recurrent failures, we use both of them.
Okay.
PRP actually mostly when we are not getting a good endometrium, that is the cases where we really want to use PRP. And embryo glue is basically when we are seeing that endometrium is also good, you are transferring a grade 1 embryo, there is no problem, and still patient is not able to conceive. I feel at my center, if I have to use, I'll use it this way. I mean, PRP for those ones who really don't have a good endometrium, giving them and trying to at least get a thickness. But as Mona rightly said, there is a nice paper in ESHRE which took a huge number of studies saying that endometrial thickness is not something which we should worry about now. I'm not sure. I'm a bit skeptical to, really take it as ki, okay, it is being written, so chalo, let's leave it and now do whatever we want to do. But these are the two differences where, PRP for endometrial thickness and glue when everything is fine and you don't have an answer, so that you give a glue for the patient also. And even, yeah, as some studies did say, it has an improvement. So yes, by on that evidence also, we can say that we are using it.
And in thin endometrium, like if that is the maximum one for that patient, say 6 is the maximum that we are able to reach for a patient with everything. I mean, with the also, if it doesn't work, and if patient consults some other doctor, it is the first thing that the comment will be there that, oh, ये 6 ही था तो आपका किया क्यों? So many times, after a failure, it becomes retrospectively very easy for us to like say that this would not have worked. But I have had natural conceptions with 3 and 4 endometriosis.
So
you are lucky.
I think we have to take that with a pinch of salt.
Yes.
And with a lot of counseling. Because ultimately we should let the patient take the decision rather than we take for them. And there is a role of sonohistography, SIS also for endometritis. There are signs similar to the signs that we see on 2D and 3D, but a little better contrast enhancement. MRI also has many signs for about chronic endometritis, which I think we are running short. Again, diffusion weighted imaging will give a better idea about chronic endometritis. There are more advanced and emerging techniques coming up, contrast enhanced ultrasound, elastography, which will judge the stiffness of the endometrium and many things. The atrophic endometrium, again, we can discuss. There is a chronic endometritis scoring system that if anyone is interested, they can review that. So you can, from ultrasound and MRI combined, we can give a scoring and then we can put a diagnosis. And again, clinical implications, I think we all have already discussed that, but what we should be doing for that, there are strong indications like when this is required and what all should we look for, and then protocol of treatment. Basically, we give an antibiotic. If it is COX, then we need to give AKT for them. And along with that, a probiotic is very important because it helps in reducing endometritis. Sometimes is only inflammation and not infection. So many times we see a lot of inflammatory endometrium on hysteroscopy, but the biopsies come normal. So those are the cases where it is not infective endometritis, but it is just inflammation. And many times, like personally, we use hydroxychloroquine and other probiotic along with anti-inflammatory agents to reduce that. And there are some some other diseases mimicking a chronic endometritis, which we should be aware of. And the cycle phase, these are the limitations where, it may vary with the phase of the cycle where we have seen, and there are some technical limitations which we should be aware of. So with that, I think, and there are a lot of new cases. So the first case, the euploid embryo one, where the third case, these were the findings. So on imaging, the volume was 2.1, which was borderline low, as Sonal ma'am had said that less than 2 is something which we should be worrying about. VI was 6.5, which was hypovascular. She was hyperperistaltic. So the implantation failure score was 14, which was higher risk. The interventions done were vaginal sildenafil and nifedipine, and targeted transfer was done in the vascular when the vascularity improved and in the correct zone, and it's an ongoing pregnancy. In the 5th euploid transfer. And these are more advanced techniques which will be coming up. There would be AI powered predictive models. So I think we with those things, no, and these will be there in 2 to 3 years, I guess. So we just put the probe and it gives a whole, data about the endometrium and the flow of the patient. So I think we can, if there is there time, we conclude.
Let me ask Dr. Basir once. You continue with the same. Meanwhile, I am asking ma'am, is she going to give her talk or not?
So, Ekika, can you take this one? Or?
So this is a case which is, she is a 28-year-old and AMH is normal, AFC is there, but still there were only 2 mature oocytes which were retrieved in the first IVF cycle. And many a times when you counsel a patient, you see that AMH is good, follicle is good. So we tell them, don't worry, I think we will get good numbers of M2 and we can give you good embryos. And suddenly you land up only with the 2 mature oocytes. So what are the things which you will be looking in this case, so that you can counsel the patient, and what protocol or what other thing which you will be planning for the next cycle in her case?
I think critically evaluate the your dosing and trigger. This two and timing of trigger. These 2-3 things should come first.
Yes.
Apart from some idiopathic thinking that it is only idiopathic, rather than we should critically see ourselves that whether my doses were correct, whether protocol was correct. Thirdly, whether my trigger was perfect given in time. So something somewhere I have a lacuna. That is first thought process.
Yes.
After that, secondly, you can think that maybe she has a little less M2s only. That is another thing, because she is not empty follicle syndrome. She has given 2 M2s. That means she is a case where she is giving M2s, but maybe somewhere, or maybe the cold chain is not proper. So again, you have to go back in the whole story of the things, retro, like a flashback, and where things went wrong at what place. That you have to think first, and then think about maybe she's a poor responder.
I think, ma'am, you have said a very correct point. Whenever we come to this case, See, these are the advanced thing which we are going to see. But before that, we have to retrospectively see about what all madam said, the dosage which is being used, the duration, the timing, whether all the follicles were mature at that time, whether we gave, and simply for that time doing a Doppler and seeing a rough flow of all the mature follicles also really makes a difference. And the E2 levels, they really correlate well with the growing follicles. So these are the first thing kept in mind. And if we find that everything is being normal for the cold chain, very same day, the rest too gave me everything and she didn't give me anything with the same injections. So I can think, okay, my rest of the things are normal, but there is something in the patient which I really have to look for. So first of all, find out that everything is normal. If it is normal and still we are not getting, so these are the beautiful articles all fetched by Mona, so that we all can learn from her what all has to be seen. So Mona, over to you for this.
No, I think it's a lot of theory, but I think many of the things, most importantly, the stromal, identifying the stromal vascularity and the stromal quality assessment, that is important, as very nicely even elaborated by Dr. Sonal. And stromal volume, stromal ovarian vascular, sometimes like we discussed previously, we see a lot of atretic cortex of the ovary. So sometimes, the cortex is like calcified looking cortex or thin cortex. Those are again the cases where, and they are avascular even. So those are the cases where the vascular mapping may help and in identifying and predicting. Because many times if we are expecting 2M2 and we get 2, we are happy. Patient is happy. But when we are expecting, we counsel a lot of good prognosis. We are hope givers. So we always give our patients a lot of hope that, okay, let's do it. And we hope and wish for a very good outcome. And then suddenly if you get a low response, no, it becomes a lot of negative feeling for us also and for the patients also. So I think in many cases, if we just do put a Doppler and see the ovary carefully, we see the hilar blood flow, and then there are cases where, one or two follicles are a little larger. So the asynchrony in the follicular pattern. Many times it is better to wait for, I'm very fond of synchronization. Because what I feel is one very important thing before stimulation is follicular synchronization. So many times, there are one or two follicles who are larger and then the whole cohort goes chaotic. So synchronizing and watching, waiting for a cycle where it is synchronized is something again which we should look for. The follicular spacing pattern, the follicular dispersion, size dispersion index. So if there are a lot of different variable sizes of the follicles, again, in those cases, many times, like there was this patient where, she had come to us with after 3 failures. Every time she was given 450 gonadotrophins and she was getting 2M2, 3M2. And we just gave 150 dose of gonadotrophins and we could get 12M2. So, which was higher than all her 3 combined previously. So, because when there are these asynchronous cohort, what happens is the larger follicles have more FSH receptors. And when we give a higher dose, those receptors are all saturated and they grow faster. So on day 6, there are 2 big ones and the rest of them are lagging behind. And when you give a lower dose, the smaller ones are saturated but not the larger ones, and that leads to even growth. So the smaller one has a chance to catch up with the larger follicle. So I'm actually very fond of synchronization, and a low dose stimulation is what I usually prefer. I never go beyond 225. So most of my stimulations are 150, 175. And they always give a better M2 as compared to the AMH levels. And the dose I decide as per the BMI mainly, irrespective of the AMH or antral follicle count. Then there are some advanced ovarian testing also, like again elastography, which now we are not doing. There is a ovarian reserve topography also again, and advanced Doppler predictors. So, like the stromal versus follicular flow discordancy, the ovarian artery Doppler, which many a times we just do it. Like personally, I was always doing it for transfer cycles, but then because most of us now have shifted to frozen transfers, but then it can even help in the ovarian monitoring cycles as well. And these are all the components that we can see in the imaging to judge or predict or maybe counsel our patients regarding like the expected ovarian response. And so which includes the cortical thickness, the stromal echogenicity, the vascularity index, the follicle clustering pattern, stiffness, which we right now don't have, elastography, the RI, and all these on day 2, day 3, it helps us in predicting the response and again deciding our stimulation dose. So if it's a very low vascularity and low flow and maybe a very thin cortex and atretic cortex, maybe they need a higher dose irrespective of the AMH or antral follicles. In all the other cases, probably a lower dose may help. And just one more case, like can we detect an empty follicle syndrome or can we predict an empty follicle syndrome before we do the egg retrieval? Or if at all, if we have got an empty follicle once, can we help the patient out? We have ruled out everything else. The trigger was perfect and everything was good. Maybe we have given a dual trigger and everything was there. Still, we got an empty follicle syndrome. And the LH polymorphism is also normal. So there's no genetic factor and there's no trigger issues. Are there any signs on ultrasound? Anybody has, found some signs which can help us in predicting?
Decreased ovarian perfusion. So maybe ovarian artery Doppler can be of use because it is the vascularity which is defective apart from rest of the things also. Like cortex is very thin, you have a very small ovaries, and like stromal flow is also not good. So like overall ovaries are not looking good. But sometimes we have seen that even with a very good ovaries also you get an empty follicle. Once empty follicle, don't take this as a dictum that she's a case of empty follicle and go for your OD cycle. We had two cases where previously we had empty follicle, but next after 3 to 4 months of proper suppression and then stimulation, we have got a good follicle and a baby of their own. So that is in my cases, I had seen twice that empty follicle, and that was only 2 cases of empty follicle I had till date.
We had to give more time for the to see each and every follicle.
True. And I think Dr. Sonal has helped us here by, she nicely described like a low perifollicular vascularity. This can help even in an IUI. Because
Yes,
when we are just
that is true.
triggering an IUI, when these signs are there, usually they do have either an empty follicle or an LUF. And then like doing an IUI doesn't make sense. So the same, the same criteria we can even use for a natural cycle or an IUI trigger as well.
I mean, the 3D, you can see the cumulus in the follicle.
Right. So all the 4 signs that she had nicely described, the low vascularity, as ma'am rightly, Dr. Ojaswini rightly said, absent cumulus, thin-walled follicle, and a very rapid. So sometimes we see 2 follicles on day 6 of stimulation around 22 mm. Those mostly turn out to be empty. So probably in that case, when we are doing an IVF, we usually tend to ignore those 2 and follow the rest of the follicles. We wait for the rest of the follicles to grow.
Mona, I wanted to ask you, you said you always start with the low dose protocol. So what is the BMI management and what is that you give? Do you give recombinant only or you give the combined?
I have been using clomiphene with recombinant in all the cases, irrespective of the age and AMH.
And what about the BMI?
BMI is around till 25, 26, I give 150. If
Okay.
it's 27, 28, around that BMI, it's 175, 29, 30, around that 200. And beyond that, up to 35 to 25. Very rarely, like if it's a 40 plus BMI and all, I go to 300.
So clomiphene you give for the whole till the day of trigger or only for
The
5
day
days?
of trigger, till the day of trigger.
So with that, do you have to give anything
And
for
dose
this?
100?
Even
Clomiphene dose
agonist
100?
is not required.
So you don't give anything for the suppression
That
of
also not required.
not required. So with this, you get hold of both the things that
We get a lot of better number of follicles, even in very poor responders.
Okay.
Many times,
And
we see that a patient of, say, AMH 0.3, 0.2, and when we give clomiphene, they develop 2, 3, 4 follicles. But when
yes,
we stimulate for an IVF,
they don't. They don't. They
So
don't.
it's the same thing. So I think many a times, adding clomiphene, I have found very good response, especially in poor responders. And in normal responders also, we started using because it saves a lot of money and reduces the dose of gonadotropin a lot. And it has
Never
given
had to use antagonist. Because I have seen with the CC cycles, people not using antagonist also.
I'm
So
not using.
You get proper less suppression.
There have not been any case of premature rupture.
So what is the dose of clomiphene, Dr. Mona?
I give 100 milligrams till the day of trigger.
Bapre.
So then we get a very good cohort of follicles.
And how do you decide the day of trigger when after clomiphene?
If majority of the follicles are around 17 mm, I give. But beyond, so my range of trigger is 14 to 18.
100 milligrams.
100 plus 150 recombinant FHS.
150 recombinant. Because it does compensate for the, poor responders LH deficiency.
Yeah, that is good. That is for poor responders. It is good.
Because with HMG, we found a very large number of cases of poor quality of oocytes.
Okay.
Even with PCOS, you
Since
are giving
long,
them?
I have stopped using HMGs at all. I mean, there are doctors who have been regularly using HMG and still getting outcomes. But personally, I feel that recombinant has always given a very, very predictable outcome.
And
Even
after
in
that,
PCOS, you are doing clomiphene plus recombinant cycle?
And when do you give HCG in such cases?
The follicle size.
When do you give HCG or not after recombinant FSH you were giving?
For trigger, we either, if it's a poor responder, a dual trigger. If it's a PCOS, analog trigger, and normo responder also, I prefer to give a dual trigger only. So most of the cases go for a dual trigger, and probably some PCOS or hyper responders for analog trigger.
Okay.
Madam, can you repeat how you are giving CC 100 milligram? Hello?
So from day 2 till the day of trigger. So usually most of our stimulations are, my average stimulation dose is 1350. For last 2 years.
Have you put it in a paper? Because this is really good.
It is a different one, na? It is a
I'm going to
different
try it,
protocol.
Mona, and then I'll definitely revert back to you because this is
Very
amazing.
consistent results. So we have never faced any Posidone 1 cases.
Very nice. Very different. You should have
Good.
present the
We all
case.
must use it. We all must use it and try it.
And it saves on antagonist, it saves on the gonadotropin.
No antagonist to be given. No antagonist to be given.
Everything
Very
will go away.
synchronous growth as well with the low dose.
Very nice protocol. Different protocol, not now. Very different protocol.
We are in the process of publishing, previously when we were using the ANTAC protocol and comparing with the long CC protocol. So,
Okay.
but it most of it, the stimulations are just 8 days.
In this case?
Yes.
By 8th day, you give a trigger and you're getting follicles.
That is there. In most of above 50.
Wonderful. You have to publish it, huh?
ये तो मोना जादू की पिटारी खोल दी तुमने
हाँ
सब।
we
अभी
will
तो सीसी
we will do one more
Yes, yes.
webinar with Dr. Mona for
Bunch
stimulation
of
protocol
yes,
only.
yes. And
because
I'm
it
also
is a
going to do few
different.
cases, and if it is good, it's good. Actually, it is good for the patient and even for us
Yes,
also.
patient.
You are
Yes, yes.
absolutely right in saying that, sometimes when we see a dysynchrony or we are saying it is not going, we go up to 450. Even in elderly patients with few follicles. And I used to wonder exactly the same thing with clomiphene. When they can come up with 3 or 4 follicles, then why not with this? So here
But
is now the
nowadays
answer, which is there.
everybody is shifting on letrozole more than CC, right?
I'm personally very fond of CC. Even
Is there
Letrozole,
by
it gives a monofollicular development. Letrozole's physiology is to cause a monofollicular development. But in IVF stimulation, we want multifollicular.
Multiple
So I think the CC protocol has to work wonders if it's
If it
working.
is
So that
published
will
and
work with
it is
all of
best,
us.
right? Wonder,
uh,
wonder.
Yes, yes.
excuse
Looking
me,
forward
Dr.
for
Mona?
we have Dr. Sheesh Kamal Sunkara on board.
Okay. Oh, that's nice.
So we'll
That's
be
good.
doing more of, taking her help and doing a lot of publications this year, hopefully.
That's nice. That's good.
Because, we are pure clinicians. We keep doing work, but then
But we don't know how to do that. But when
time
Kantara is involved,
publishing,
definitely we're expecting some good papers from your side.
Wonderful.
But
Very
Dr. Mona, has there been by any chance that you needed to cancel the cycle? I mean, you go on with the clomiphene when it is 17 millimeter, then you add a recombinant FSH, and then at what time do you give the HCG, the dual trigger? That's what I am interested in knowing.
CC with recombinant also from day 2 only. It's a combination protocol. Not only CC, it's CC with recombinant. And
Okay.
So you are using alpha or beta?
But in different cases, different. Many a times biosimilar also we have been using because of the cost effectiveness. And in our data, like all the three have given equivalent birth rates.
Okay.
Wonderful.
So I think with that, we can skip the rest of the things because it's all futuristic, more futuristic than current. And Dr. Ekika, can you just wind up the panel?
Yeah, we are having now
Yeah.
time.
Yeah.
So
Well,
the lecture is not yet, it's
so
canceled.
probably, yes, I really want to say after this discussion of our with the beautiful panelists and a beautiful presentation, more so by Mona, I must say it again and again because it's her work which is really being given. So, I mean, we should think of imaging also as a part of our treatment protocol when we individualize it for the patient. It should not be missed. And obviously, I mean, we are not a radiologist, so many things we might not be able to see. And secondly, many of these things are being seen beautifully only on very high-end machines. But few things like on 2D ultrasound and the Doppler flow are something which we can really go and check and can know what to be done for it. So with this, I really want to thank everyone. I want to thank the society. I want to thank all the panelists to be so interactive during the session, and Mona and Dr. Brishbala, and my a big thank to Archana Madam to involve me in such a wonderful interactive presentation. So it's a thanks from all of our side, and obviously UNS, thank you for giving us a platform where we can discuss so many advancements. Thank you very much.
Thank you, Dr.
Thank
Ekika,
you.
Dr. Mona, Amrita
Meeting
ji,
all
Dr.
of you.
Kanchan, and
Yes.
everyone. You have taken out time, and it was beautiful discussion going on.
Very
So
beautiful.
many futuristic things we heard for the first time, and I think it is going to help us in our practice and for our patient result also. So wish to meet you all again in Indore. We are having one VP conference in May. So I invite you all, and at the end, I wish to uh, request you all to support Dr. Archana Basir madam. She is contesting for President Foxy, and our own Dr. Bakshi ma'am is contesting for VP ISAR. So I request all of you to support both of them.
Thank you.
Definitely,
Thank you
we are
very
there
much.
with all Indore people.
Thank you.
And
Yeah.
gratitude to all of you for inviting us also for this wonderful panel, which has a many key point to take home and practice from tomorrow and improve our success rates. So thank you. Heartfelt thanks to all of you. Thank you.
Thank you.
Thank
Thank you
you.
very much.
Thank you.
Thank you.
So thank you, everyone. Dr. Brijwala, with
It was wonderful.
Thank you.
right. So
Thank you,
final
Dr.
word of
Brijwala.
thanks,
Thank
Dr.
you.
Brijwala. Can I
Thank
do
you.
it on behalf of UNAS?
Thanks, Team UNS, for providing us platform. Thank you so much.
Okay,
It is
thank
my
you.
request that add me in the same future if you are going for this conference like that. So I will be happy to attend your all the ISAR meetings. Thank you.
So thank you,
Thank you.
all
Bye
esteemed
bye. Good night.
doctors,
Thank you. Good night.
speakers, panelists, and
Bye-bye.
monitor.
Good
Thank you.
night.
Thank you,
Have a
everyone.
great
Have a
time.
pleasant evening ahead. So Jignesh, you can stop the event.